flattering introduction, and thanks everybody for your time. Just I do have a few. We just want to come up. I'll start talking. The patient story I'd like to present is a lady called Anna. But before we go into Anna's story, the background behind that is around the stroke services coming together. So we formed the North Mersey Stroke Service, which was a collaboration between what used to be the Royal, Aintree, and then Southport Stroke Service, all coming together. And we did that because we believed that by coming together, we could deliver a better stroke service than we could as separate sites. And that was the driver for us coming together, but it was accelerated by Aintree and the Royal coming together to form LUF at the time. But I'm very clear that it was us who wanted to do it rather than being sort of pushed together. Following on from, we've got our slides up. Just so this is the logo for the North Mersey Stroke Service. This is our combined service between the three trusts. You can see the geography that we've got in the top bubble. That's the Royal and Aintree near each other. Southport's a little bit further away, but we felt Southport's service was struggling to sustain itself just due to a lack of consultant staffing. And so by bringing Southport into the service, we were able to actually build a better service for ourselves and better service to people, population of Southport. And of course, that needed a lot of engagement with ambulance services and everybody else to deliver the best possible service. And we all came together in September 22. A year later, in September 23, we opened our Stroke Emergency Assessment Centre, which is just the bit with the green roof over it on the far right there. So we're next door to A&E and next door to the Medical Assessment Unit. This is the only Stroke Emergency Assessment Centre in the country. Was at the time, still is, but other places are starting to experiment with similar concepts. The idea of the Stroke Emergency Assessment Centre is patients can walk straight in, or ambulances can take patients directly there, rather than going to A&E, queuing up for a long time to get into A&E just to be seen. So our stroke patients get seen rapidly. We have our own CT scanner and our own stroke team based there, so patients immediately get access to stroke specialist care and can get a rapid CT scan. And if it turns out they don't need stroke and they actually need A&E, we're next door to sort of seamlessly move them to the right place for their care. And crucially for us, we're next door to the Walton Centre, because one of the big things that's changed is the technology that we can offer through the Walton Centre, and particularly thrombectomy, which is where we use a wire to pull out the clot that's causing the patient's stroke. And if we do that quickly, speed is crucial. It can have a dramatic impact for that patient. So we know every minute 2 million brain cells die in a stroke patient until we can do something to prevent that happening. And this is our team looking very happy because we feel like we're delivering good care, and actually the team are very happy working at the Stroke Emergency Assessment Centre. And since we came together, we've consistently been a grade A in the national stroke audits, and actually at times been top in the country. The last quarter we were third in the country, and early last year we won a national parliamentary award for the stroke service as well, which we're very pleased with. So I'll come on to Anna's story now, and I could describe Anna's story, but I felt the BBC did the work for me, so I'm going to play this short documentary. It's 3 minutes long from the BBC that will talk you through what happened to Anna. Okay, so thanks. Let's just talking about how they get access to physio, speech and language and occupational therapy. And then this lady's talking about how crucially the Walton Centre being next door is what's allowed us to get patients in very quickly and then get that treatment at the Walton Centre where they can have the thrombectomy. Whereas before, if you turned up at the Royal, you might get assessed, but then might wait some time for an ambulance to be free to get you to the right place. It's all about getting to the right place as soon as possible to get the right care. I have no idea why the sound's gone off, but hopefully I'll just carry on talking. So what I think this story from the BBC doesn't really explain as well as it could is that when Anna came in, she had a big blood clot blocking an artery in her brain. If that wasn't treated quickly, she'd almost certainly have been left with lasting speech problems, what we call expressive aphasia. So an inability to get out the words she wants to say and essentially talk gibberish, thinking she's saying the words she wants to say, but the wrong things coming out. And as you hopefully heard at the start of that video and would have seen at the end, she's now talking completely normally, riding her bike and essentially living a completely normal life back to where she was. And there's, is it possible to skip to the next slide? It seems to be working on here. But there's Anna's given us this sort of short summary of how she feels. And she said, my recovery has been incredible. You wouldn't know I've suffered a stroke by looking at me. Within 2 days of being discharged, I was visiting friends and family and planning when I could go back to my walking club. I also felt fit enough to return to my spinning gym classes just over a week after my procedure. Prior to my stroke, I was planning a trip to India. And thanks to the wonderful care I've received, I'm still able to go. And that's why we were all behind this from the start. We knew we could have that transformative impact for our patients. And that's why now we're really keen to work with the Walton Centre. And fortunately, Walton are keen to work with us. And again, fortunately, it seems our organisations are coming together, which again will accelerate the impact we can have to do even more in the future. And we've been getting national attention. That's Chief Strategy Officer of NHS England, Steve Powis, all come to see our centre and have all been very impressed by what we're able to do. So thank you very much.
Thank you. Fantastic. Great work. Jim, do you want to say any more before I open up for questions?
Well, I think it's been said, so no, I'm nothing to add.
Thank you. Thought or question, Jeffrey first.
Thank you. Thanks very much for the presentation. I previously on the board at Merton West Lancs and stood on the board at Southport. And when we first went to realise it was a fragile service with the stroke, and actually it was dangerous. Not just fragile, it's a dangerous service. And I had the privilege of going to the stroke ward last year and speaking with patients and the staff who just spoke miraculously about the service it had here. And what was so good is seamless transfer from Southport. When you need your acute episode in here, then you go back to Southport for rehabilitation. So absolutely fantastic service, and the patients just spoke so glowingly of the care they'd had. So well done.
Thanks, Jeff. And Chris next.
Thanks, Chair. Thanks, Nick. Great presentation. Stroke service is something I often refer to as a prime example about how patient pathways are prioritised clearly over organisational boundaries. And I think just wondering, as you touched on, we're kind of looking at how we work together as organisations more closely. I'm just wondering if there are kind of lessons from your experience of working with colleagues at Walton and how we might take that forward as we kind of look to develop the group longer term.
Yeah, absolutely. I think our experience is coming together between the Royal and Aintree. We're lucky that I think there's a bit of a stroke community, so we already know each other and we're able to have those discussions fairly easily. And I think the key is that everyone was behind a vision of what we could achieve in the future, and it's very much led by our clinicians saying, this is what we think we can do, and let's now try and make it happen. The organisations coming together made that a lot easier, but I think it happened because of the clinical vision more than anything else. And again, with Walton, we're talking to each other. We've got a vision for how we can help Walton achieve their goal of doing more thrombectomies. And actually, that's the same goal that we have, doing more thrombectomies and improving the outcomes for these patients. Sharing that vision has been, I think, the key thing. And if you find that compelling vision for each service, people will do what is needed to make it happen, I think.
Thank you. Heather next.
Thank you. Great story and narrative for organisations working together. I'm really interested in the staff experience as well. You saw that picture of all the happy staff. So how, are you seeing that we're attracting people, the best people to come and work in our service because of the success of the service? And are we working with the Walton Centre to look at sort of joint roles and shared roles? Because I'm really interested in that. You're saying all the staff are really happy because we've done something really successful.
Yeah, I definitely think there's a lot of enthusiasm. People are happy because the care is great, but they also feel like they're doing something at the cutting edge, I suppose, which is exciting for staff. I'm almost worried a little bit because I've got another role in the stroke network that we're seeing consultants wanting to join us. I'm worried about the other services around us slightly. We're having to think very carefully about how we get that balance right. So we're definitely bringing staff in. And again, with the Walton, from the start, 2 of their neurologists have been part of our service. We're very interested in how we make thrombectomy more sustainable by maybe sharing staff across theatre suites, because one of Walton's biggest challenges isn't having enough interventionalists, the consultants to do the procedure, but having the theatre staff available, scrub nurses out of hours. So I think collaboration with Walton will absolutely help us get to the next level and what we can achieve.
Tim next, please, then Jackie.
Thanks, Chairman. Thanks for the presentation, Nick. I remember in previous roles where stroke and getting SNAP scores up has been the bane of my life, and you've got second responder nursing pulled into the general nursing pool and all of that sort of stuff. So the model is great. I've got one question was around sort of this afternoon we're going to the Integrated Care Board to present on the wider case for change we've done, and it does pull out things like SEAC as an example of best practice, but when we've got thrombectomy, there is headroom for improvement. And it sounds like the relationship is good, but I'd be interested in what must we get right as we come together as 5 trusts, and how can we really help to accelerate the work that we're already doing with the Walton. And the other was more, if we clearly sort of ambulance will go straight to the SEAC, but if we do get patients presenting to the Royal, how do we make sure we get the same levels of standard and care?
So to answer the first question, in terms of what we can do working with the Walton moving forwards, I've already had a lot of chats with Sasha, who's the lead radiologist over there, and Andy Nicholson as well, sort of start to scope this out. And there's definitely benefits in sharing. As I mentioned, the scrub nurse, Walton are paying for people to be available when they might not get a call all night, whereas if you've got emergency theatres being used on this site, there's, we can share those staff between the 2 areas and have real benefits. Similar with anaesthetic support, these procedures, if they cover that little extra area, it'll lead to efficiencies overall. We think we can help Walton because when they get stroke patients coming to them from Chester, say, or Arrow Park or Wiston, they come to Walton and potentially wait on a corridor or a non-stroke area until they can go in. And they'd like them to come through our front door, wait on SEAC, then go there and come back. There's a little bit of work to be done about our capacity to make sure that's feasible. But with some of the estates changes that are happening, we can hopefully factor that into the longer term plan to make that an option. But the key thing is we get on very well. I think those personal relations make such a difference. We get on very well with colleagues at Walton, and we all want to make this change together. In terms of service for patients who don't get to the right place first time, I'll admit that is tricky. Fortunately, it's a tiny number of patients where we've had issues for 2 in a year. So the much superior care for everybody else outweighs, I think, that small number of patients. And the big problem is when we planned this, ambulance services were more responsive than they are now. So now somebody could be in the role, we want to get them to entry, but there's a significant wait to transfer them. So we've been looking, we do use telemedicine to see people on the other side to make plans whilst they're waiting. And we're about to roll out pre-hospital video triage, and we've just had a recent meeting where we've agreed that we're going to do this across the Northwest. And the idea is that actually from the ambulance, that patient will be seen by a stroke clinician, and they will make a decision as to where's the right place for them to go. And then when they get there, we'll be ready for them, already ready to treat them immediately. So that should massively cut down on the number of patients ending up in the wrong place. Should save patient time and also save NWAS time by being more efficient for them. And in fact, there'll even be some patients where we say to NWAS, don't need to take them anywhere. They're fine, just leave them where they are. Because it's more likely a migraine than a stroke. Or we can say they don't need to come into hospital right now. I'm going to give them an appointment tomorrow to come to my clinic, and then we'll talk it through. So there's lots of efficiencies to be gained there.
Thank you.
Really good. Thank you. Jackie, next, please.
Thank you for the presentation and for hearing Anne's story, because it was a great story to tell. And I did spend an hour in your unit just before Christmas having a good look round. I'm just interested as well for, they're not always good outcomes, are they, for some patients? And how do you deal with the patients that are not recoverable? How do we make it a good service for them around privacy, dignity, if it comes to it, a good way of dying?
I think there's two answers to this. There's the patients who do have big strokes, and no matter what care they get, unfortunately, they're still going to have a big stroke. And the key is good rehab. One of the reasons the Southport Stroke Unit is still there is to want people to be able to go closer to their homes for that rehab, rather than being at Aintree. So good quality rehab makes a difference. Recently, the national guidance for rehab has raised the bar on the amount of rehab we should be giving patients, something like 6-fold. So it's a real challenge to hit that level, but that's our challenge to take on and trying to achieve that. And we're using things like digital rehab to be more efficient with the care we can give. There are inequities across Cheshire and Mersey in terms of community stroke rehab. Liverpool Stroke Recovery Partnership, which covers most of our catchment area, is by far one of the best ones. If you live in other areas, you'll get much less community rehab. We need to get that right for our patients. So we keep raising that to the ICB, but of course there's a challenging economic environment as well to factor in. End of life care. I think all of our staff are very well aware of the importance of dignity at the end of life, making sure patients have the right environment and that the families are brought in and kept up to date about everything. I think our SWAN team over here is excellent, which really helps support that as well for those patients.
Thank you.
Thanks.
Matt, next, please.
Thank you, Chair. Fantastic presentation, Nick. And you've already described how important some of the digital innovations are within the work you do. Within the 5 organisations, we look to put a single EPR across and simplify our digital offer. We know there's a lot of complexity. Just in terms of the benefit that can offer, and I guess that further sort of roadmap for your digital ambitions, where do you see that play? What difference can that make in your service?
I'll give you an example from just yesterday about some of our consultants, not complaining, but raising that there's an issue. We often get patients referred to us from Liverpool Heart and Chest because if they're having cardiac surgery, unfortunately, they're more prone to strokes. And there is an issue in how we document the advice we've been given, how we can actually see the notes, because these are cardiac surgeons telling us about a patient might not have the same insight that some of our medical doctors might have over here. So having access to that patient's notes would help us make better decisions and also make us feel safer that we're able to document our decisions in the record. Same with the Walton Centre, to be able to share their records because we're essentially dealing with the same patient. So it makes sense to be able to share records there as well.
Peter?
Yeah, thank you. Nick, you really answered my question, but I'm going to make a point. The question was, what comes next? I mean, we talked all about our links with Walton and the time to thrombectomy, but that pre-hospital bit was the bit, and you've already answered it. And I think that is what's coming next, and it's important to remember that. But it just helps me make my point, really. This is real transformational change, I think, when you think about it. And Nick's been very, and it's with patients absolutely the sense of the stories, absolutely amazing stories are here. And Nick, you weigh a lot. And you're too humble to say, but that way is the clinicians. That is the frontline clinicians saying this is the right thing to do and being empowered to get on to do it. I think remember that's what we went to our transformation plan next year. And then finally, for me, I talk a lot about the several front doors at Aintree ED, and this is a real blueprint about if we can get that right, how we can get the right patients to the right people, the right time and decongest the ED, which here later is a big problem for me at the minute. So this is a blueprint I want to work with, and I think we can really.
Thanks, Peter. Well done. Tom?
Thank you very much for the presentation. I was emailing you during the week to talk about research. I wear a university hat as well, so that was me chasing you. So maybe you can just comment briefly around what do you see the possibilities for research here across the city as a whole or in your own centre?
Yes, and I think there's big overlap between what you said about City as a whole and our centre, and we do work very closely with our colleagues in the other trusts as well. When we came together, our research increased massively overnight just by having all the patients coming through one common door and one research team based there to capture those patients. I'm afraid I don't have the numbers to hand, but there was a significant step up in our research capacity. And actually, again, our clinicians are really excited by this, and we've had lots of conversations about what we want to achieve. We feel we've put stroke on the map in Liverpool clinically, but we also want to put ourselves on the map as a research centre and a driver for innovation. And those conversations have led us to talk about how we bring in a professor who's going to lead with the university on doing our own local research. We've worked with, talking about the pre-hospital things, we've just launched the Speedy trial, which we think will transform the way stroke care is delivered in the future. Speedy, it involves ambulance crews looking at stroke patients and making an assessment and saying, you're likely to need a thrombectomy. So instead of taking you to Chester, say, which is the nearest hospital, and then Chester doing their assessments, and then calling Walton and then getting another ambulance, we say, we think you're going to need this treatment. We're going to get you straight to, in most regions, it will be straight to the thrombectomy centre, but over here, straight to Aintree, where we'll do the assessment and then move you to the Walton Centre afterwards. So we're at the forefront of that because we think that's the model we'll do in the future. So we thought, let's be involved in the research now so we're ready. But now we're adding on another level with a finger prick blood test, which can identify a likelihood of a large vessel occlusion to make that even more accurate. And we'll be the first place to do that as a screening tool to decide if patients go directly to the trust. Not sure if I've answered your question, but the short answer is research has increased significantly since this happened, but we've got a real appetite to take it up 2 levels really and be right at the forefront and a national name, international name for stroke research.
Excellent.
David. Thank you very much, Chair. Thank you. That was again a really great presentation. I think really what really comes across very loudly is the true professional nature of the team that are providing care, both from the very acute onset all the way through, and how vital our colleagues in allied health professions and nursing are as part of this. But it's a great opportunity for us as an organisation to be able to celebrate that speciality within those different professional careers. It does make us a more attractive place for people to not just come to, but recognise that their careers can flourish. But of course, that knowledge and expertise just stay in that service. It permeates and spreads across the whole of our organisation. And so thank you, and thank you to your colleagues.
Thank you.
That's great. Thank you very much, Nick. And a huge thanks and congratulations to you and your team for making all of this work. It's a fantastic story, and as we saw from the BBC clip, it's affecting and improving lives for the whole of the population that we serve on a daily basis. So it's a great story. I think for us as a board, there are 2 sort of themes that come from this that we carry into other aspects of our business and discussion. One is that what's the formula for really good cross-organisational partnership with other hospitals? What are the ingredients that really make that work when it works well, and how we learn what we can learn in some other services about that. And secondly, the point you make about the community infrastructure, and we know the ICB's got a lot of priorities and they haven't got enough money. But I think we as an organisation can be clearer about what are those things that are really at the top of our list when we want to do that. I'm sure we have lots of different discussions with them about different bits of service. All of that together into it. I know you're going to the ICB meeting later this afternoon. Maybe you could mention that. Just while I'm here, I've got another thing I'd like to mention. Thank you very much indeed.
Thank you.
Thank you.
So much. Thank you.
With the minutes of our meeting that took place on the 19th of December, I know there have been a number of adjustments to the minutes in response to board members' input. Holly, is it the final version now that's on live?
Not the final version on. What we'll do
the amendments that were submitted in advance and then in the next thing.
Okay, thank you. Peter?
Sorry, this is one typo in the entry update. It says there was 15 risk registered, there was 11. I think it was a typo. There wasn't 10 new risk, I think there was one. I think it's just a typo.
Thank you. Jackie?
So I just wondered if I could pick up an item that I brought up in the last board meeting, which was around the increasing pressure ulcers that we'd seen in the last month. I know they've gone down a bit this month, but I just wondered if, David, you'd be able to tell me about the review that you did and if there's anything that we needed to know?
Yes, thank you, Jackie. So we looked at the information, and the information we gave last time on board was correct, that those areas, particularly in the assessment areas when we had a much higher level of activity and congestion within those services, were the areas where those pressure ulcers mainly occurred. What I'm pleased to say is that with the attention that the organisation is given, we have now started to reduce those.
Thank you.
Thank you. Okay, I'll ask for then a provisional approval of the minutes if all the amendments that are made are in yet. Anything in there that anyone has any concern about? I'll ask for that, and then we'll receive the adjusted minutes again at the next meeting. One consent. Thank you. There are no open actions on a rolling action tracker, Daniel, and I've not been notified of any urgent matters arising, so we'll go straight into the Chief Executive report.
Thank you, Chair. A few things I wanted to draw out of the report just to update on, and I'll just come to a couple of colleagues for updates as well. The first one was the winter pressures, and obviously it's been exceptionally busy period, not least in the period. I've included in the report reference to the incident that we declared at the beginning of January and what that was about and how that worked. I think I just wanted to describe to the board that situation. We've subsequently had a good look at the data, and there were certainly two major peaks of flu. One on the day we declared the critical incident that was a large peak, Royal, and then an even bigger peak the next day at Aintree, as it sort of seemed to move through the city south to north. So those two things combined with the usual lack of egress during that sort of Christmas New Year period really did create an unsafe situation, really. So we declared a critical incident, as everyone's aware. I just want to put on record that the EPRR team, which Beth oversees, and Natalie and Peter's teams on both Aintree and the Royal did a brilliant job of getting us back together within a couple of days. It was a good recovery from a really difficult position, I think. And I think by the weekend, so within 2 or 3 days, we felt it could be stepped down. NHS England asked us to continue it over the weekend just to be certain, but we're in a good position. You'll see from the data today in the packs that there were some really difficult measures there that were affected in that period again, like ambulance handovers particularly. And I'm not going to comment on those because we'll hear from Aintree and the Royal in their individual reports around urgent care shortly anyway. I did want to note though that it was good to see even sort of throughout that duration of that period that the triage times were still really good. So we were still making sure the organisation was as safe as we possibly could be. But it was a really difficult period for us. So beyond that, we've then got an update on the CQC, who since our last board meeting have been in numerous times. They've written to us about Aintree and the Royal, which landed at just after our last board meeting. Subsequently, there's been an inspection at Broad Green. So just going to ask David just to give us an overview of that. And then when we come to the details of the letters that are included, particularly around Aintree and the Royal, Nat, people pick those up in the reports that they do later. But just an overview from you, please.
Thank you very much, James. Colleagues will be aware that the regulator, the Care Quality Commission, have visited the Trust a number of times since October, and I thought it would be helpful just to give us a brief summation of why they came. And it's really important to note that the inspections were carried out not because of any concerns with about our services. It was more around due to have our services reviewed. I won't dwell on the October reviews of medical services, both the Royal and Aintree, because we've gone into those in previous meetings. But we had an inspection of our urgent and emergency care at Aintree and the Royal on the 10th to the 11th of December. And we've had our high-level feedback on that. There are obviously, in all these cases, issues that we need to and get things better. But overall, there were no significant concerns, and importantly, no concerns that results in any regulatory action during that visit. So issues around the documentation improvements, issues, obviously, as we all know, we voiced here around patient flow and some of the impact that has on the patient's experience within the department. Some of the issues around waiting time it waits sometimes for speciality reviews to occur with the department as well, and of course the important issue about the ambulance waiting times. There were some real positive issues that came out of that review. Some of the assessment areas were mentioned as working exceptionally well and had a positive impact, and how it was observed the care that was provided even in those challenging times was carried out thoroughly and passionately, and also the people who had been in the department for longer than we would want had their cares reviewed, were awaiting the formal reports from those inspections. And then on the 16th of January, Broad Green Hospital had their inspection of medical services. Again, this wasn't a result of any concerns to that site. A very positive inspection from the high level feedback, and the inspectors found that the care that was witnessed was very patient centred, and the staff came forward and offered experience about how they felt supported within their work. Again, there are always things we can and should be doing better. There were issues around a data reporting issue around the medication prescription, some of the safe storage of wash products within domestic services, and of course we need to be more mindful in all areas around infection prevention and control. And again, we are waiting for that report to come for factual accuracy. And then on the 21st, the 23rd of January, excuse me, the trust had its well-led inspection. And this was the first time that the CQC had used a new methodology for this. And so we went through that with them, and for those of us that have been through a well-led inspection before, it felt sort of quite similar, but we know that the report may look slightly different. There are still 2 interviews to complete. Our regulator colleagues met with executive leads, specialist teams, and other leaders within the organisation, particularly from IPC, estates and facilities, and again, the high-level feedback was very positive around the leadership within the organisation's capacity, capability, experience, and importantly, visibility, and the commitment the organisation had to EDI work and to ensuring people had mechanisms to speak up if they had concerns. There will be obviously a lot more detail within the report when it comes back to us in due course. The important thing, I guess, from our point of view, that we've pleased to hear during that feedback was around the first opinion of our governance systems and the way in which we manage our own risks now. And the quote was, I love a quote, early days, but appears to be working. And so it was really gratifying to see where we put in backs up some of the other information that we've had from people like Deloitte's. The process we're on is good. And again, that report will come in due course.
Thanks, David. So a number of reports to land over the next couple of months, and obviously those will be published as and when they've been received and communicated outwardly from the organisation. Just wanted to pick up on elective reform. The planning guidance for the NHS is being released today as we speak. There's a meeting this morning which I attended with the Secretary of State and the Chief Executive of the NHS to give us the headlines. I think the safest thing to say is that largely it is, hopefully, if it comes out in the document, it is a smaller set of targets that are deemed to be important. That, as it says in my paper, one of those was the 18-week target being at 65%, but the main focus is going to be on faster diagnosis for cancer wait times. That elective target already mentioned wasn't as clear around the emergency department, other than it needs to be better than it is now. So I suspect the guidance itself will have more detail on that later today. The Secretary of State was taking that off to Parliament at 9:30, so I expect that'll be published imminently. What we do know is there's going to be significantly less money overall, and the ask is that organisations work within the envelopes that they've got to deliver on those key targets. So we'll know more about that next time. On the reform around elective, Beth's team are already starting to look at what that might mean in terms of the percentages we'll need to hit, but we also know there are widely reported in the news caps on elective activity this year and other things that are going to be a complicating factor. So we'll know more about that over the next few days, and obviously at the board meeting next month, we'll be able to give you further detail on what that's going to look like. On the rest of the reports, I was going to take a word and just go to the performance update. So as you are used to now, we've got within the CEO report the performance updates that are statistically significant from the global sort of picture of both Luft and Liverpool Women's. The managing directors of the individual hospitals will go into their own reports, but just really wanted to draw out that the positives really around the Luft side of things. A number of the improvements still remain statistically compliant or continuing to improve. We're still concerned about CDT because the numbers are still high. As it says in the report, whilst we've got 16 cases at Aintree, 8 at the Royal one at Broad Green in the last month, and you can see a statistical increase. When we've gone and looked at that across the country, it's the same statistical increase across the country. So we are moving in line with the countrywide increase, which again doesn't give us any comfort really, because from a patient perspective, it's affecting more patients than it was. But there's nothing standing out that's different. So again, David is continuing with the nursing teams in the sites and so are the exec MDs through their management boards, looking at every individual case, making sure infection control processes are being carried out and sharing learning. But there's no obvious explanation at the moment why this is happening. So we continue to look into that and we'll continue to feed back to board on any changes. I've mentioned ambulance handovers, but EMDs will cover that in their reporting because that was a real challenge during December. But as I said earlier, good to see the triage rate maintained. So we know we were seeing people early. Liverpool Women's, similar but good, good story again around the statistical improvements. So VTE, which was part of the improvement work, now statistically maintained for 7 points of data, which is now a statistical improvement, which is great. But really pleased to see vacancies at their lowest. There are very few maternity services in the country that are saying we haven't really got any vacancies, so that is brilliant. Because we all know that that was an improvement about a year or so ago at the women's, but it's being maintained, which is fantastic. So that is lowest position. And also the board has been focused on the FDS standard. And again, Jenny may cover some of this later, so I won't steal her thunder, but you can certainly see improvements in the FDS standard, significant improvements to where the organisation was earlier in the year, and the cancer target sort of following behind that. So it feels like the thing that was probably the biggest concern at the women's around that sort of cancer performance is really starting to see an evidential benefit from the work that's been going on, which is great. Beyond that, the rest of the IPR, I'm happy to take questions on which is attached, which is the Luft, all the Liverpool Women's ones, but obviously the exec managing directors will go through their key issues. We've attached the CQC letters, so everybody's got full visibility of all of the ones that we've received so far. The well-led one landed, I think, on Tuesday or Monday, so we got that out in the pack as soon as we could. And we'll just await now for the formal feedback, as David's already said. So other than that, Chair, they were the key issues. I can take any questions on either the report or the IPRs at this point.
Thank you. I find that specific questions on the IPRs probably come better after the site updates. Yes. So we'll have that opportunity after managing directors have covered their sites, but is there anything generally in James's report or any big themes in the IPR that I'm to start with? Tom.
Very briefly, I'm conscious about the issue on staff absences. And I wondered if it's possible to relate staff absences to the relatively poor vaccination rate we had earlier in the year. And I don't know if we've got the data to pull that together to make an argument for the next campaign to increase our vaccination rates.
So we haven't, just to be clear, we haven't got data on who's been vaccinated and who's not to compare to that data because we don't do it that way. There was a peak in staff absence during the same community peak in flu, which, so again, understandably, when the community rates peaked, which was sort of through December, we could see our absence rates going up. If you look at absence overall in the individual sites, what you'll see is that the main cause for absence is still stress or other issues. Mental health stress are the key issues. So it's not like the flu symptom has overtaken that, but that flu sickness has clearly given it, I think, a bit of a bounce in December. In terms of the sites, you know, it's not statistically significant of a worry anywhere particularly yet. Broad Green is showing higher, and I'm sure that will cover that in her report because that was brought up last month. But so the answer is no, we can't sort of correlate exactly. The other thing is we don't know about the efficacy of the vaccine either. But it's very clear, Tom, that at the end of December there was a big peak in sickness, which most likely was associated with that flu bounce. Mike.
Thank you. Two things. Firstly, congratulations on your appointment as chair. Chest keeps it moving. She's really good.
Me move.
I'm not too hot. Just on the critical incident, which seems to have been handled really well. From a loop closing point of view, can we expect some structured report on learnings and all of that to come to the board at some point?
So we've got a senior leadership forum on Friday where I've early side of the presentation showed the EPRR team did a review of the incident itself. So in those sort of live environment sort of situations, it's almost it feels like we're here, should we do it? And then better team go back then and say, if we applied all the criteria, did we make the right judgment? And I think in this case, it's we did. Yeah. We're sharing that senior leadership on Friday, and then I think we can provide some assurance next month. That's very helpful.
It's good. Thank you, Jackie. Next one.
So could I ask a little bit about the ambulance handovers, because I know it's deteriorated, but I just wondered, was there any knock-on consequences of that for patients, and do we know? And also, how is it now? Has it got any better?
Could we, if it's all right with you, Jackie, could we pick that up in the individual report?
Of course.
What I was asking the two exec MDs to do is there's almost different situations and solutions. So if you're happy to pick that up there and then come back if it's not answered. All right.
Okay. Yes, Tracy.
It's difficult.
Tracy, you need to stay.
I'm just asking questions now. I think again, it just perhaps getting a flavour it fed back to the individual reports, and it's really about the different CQC visits, inspections that we're waiting for the report. And obviously we've got various actions or things we've learned about. I suppose I'm interested and really good to get the feedback about our governance structure, but I'm interested in knowing how quickly individuals, out at the hospital sites, etc., hear about the actions, and how we get that flow of information out as early as possible so they can start working on and collecting evidence. So I think maybe it'd be different for each of the sites.
Well, I can certainly give an overall view, and thank you for reminding me because I failed to mention this actually in my report. So on after the well-led last week, which concluded the sort of set of visits, we issued that we had an away day on Monday as an exec team, and collated what we feel were all of the points from all the individual reports that needed actions. Rather than waiting for the final reports to come, we've basically compiled a list of, so for example, if there's a sedation policy that needed updating, well, who's doing that by when and how are we going to get the assurance? So we've got a compiled list now of actions from each of the individual visits and from the well-led. They've all been assigned to individual exec directors, and they've all been put into a plan to come back to our exec team meetings in February and March. What we've also done is had a look at where there's been something the CQC have picked up and said, this is a potential issue. If it is something where it's going to require a change in policy or process, we've put that into the long list for internal audit to review it next year. So basically, we've got Q4 to resolve it. make sure it's dealt with, and then we'll audit it and check that it's working. So there's an overarching process that we do anyway. Now, we'll still repeat that when we get the report in case there's anything in it that we didn't know or we've missed. But it's just that thing of not waiting 3 months to start the process off. So the key things that obviously we've picked out around there relate exactly to the letters you've seen a lot of the time. So Pete will no doubt cover what he's doing around the ambulance side of things in Reach 2ED. I'm sure Natalie will cover the same or similar issues that were in her letter around the Royal. And then around the well-led, there were a few things in there around particular things like some compliance data around sort of employment checks, things like that, that we've added to that list and we'll take through. So we've got a process, and what we'll do is we're pulling that together now over the next few weeks. Stuff is coming back through February to execs. And my intention will be to bring a sort of update to the board next time that says, here's where those things are at.
Yeah. My first part would have been the same as Tracy, so good to know we're going to get that back, and if we can track that over the coming months on the action. But I just spent a comment really about what to me, I read the reports on the EDs, positivity of the staff, how fabulous the staff were, and it's the old story. People forget what you say to them, but they don't forget how you make them feel.
Yes.
And to me, that correlated then with the well-led and the change I've seen since I've joined this organisation and the impact you've made in terms of leadership. Is it permeating every part of the organisation? I've seen it firsthand. So I think it's to your credit and all the executive teams spread it, that's there. And I think it's borne out too by the family and friends test that triangulates with that and the reduction in complaints. So some really positive stuff for members of the public here. The assurance of the public is the direction we're going in is absolutely the right direction. Things to learn, there always are. And we need to make sure that's picked up, followed with legal determination to follow those through. But fabulous work with the staff, and it's been congratulated.
Thanks, Chip. Okay, sorry.
Yeah, just a really minor point. I wondered on the organ donation and transplantation, whether we just add that to the action track so that we don't lose the issue of arranging a patient story to highlight the service that we provide in it.
Yeah.
Otherwise, it may just get lost in over time.
Yeah, good suggestion. Thank you for doing that. Okay, should we go and talk about the group-wide risks?
Yeah, that's sorry. So what we've got on here, so again, just to remind colleagues, you will hear from the sites about all the risks that affect our post-individual hospitals. This is about risks that come through a corporate meeting through our senior management board that I pick up. And we've got a duality sort of process at the moment because by April that will be a single risk register, but at the moment it's still Liverpool and Love. So the first one on there was around 65-week elective waiting time target, and then the overdue follow-up outpatients, and the other two around CIP and financial balance. So I'll just ask Beth to comment on the first two, if I may, which is around those 65-weekers, and then the overdue follow-ups, because I think we're getting to the point with that where we've discussed as a board, it's challenging to get through that list, so we need to make a judgment. So just come to Beth on that.
James. I'll take the 65-week risk first. James has previously reported that predominantly the challenges in head and neck at the Aintree site, and that's with capacity constraints. We have discussed this as an executive team, and we have supported the Aintree site and Pete to commission some additional support from a company who started the first clinics last weekend, and that will continue throughout February and March. So the position will likely deteriorate versus December. We are forecasting an increase in the number of 65-week waits. However, we are reassured with the mitigations and controls we've put in place with that additional support. So we are working with the teams on that recovery plan and that trajectory. So we are hoping to see that, well, the plan is for that to decrease in February and March. In terms of the overdue follow-up, so as we've previously reported, there was a focused piece of work on patients who were overdue their follow-up date or didn't have a date. And we focused on patients prior to April 2023. The number was significant, but I am pleased to report that we have now validated half of those patients. So we had 200,000 patients to validate, and we have validated 100,000 of those patients. And I'm also pleased to report that we have not seen any evidence of direct harm as a result of that validation project, which is really important to note. In December, the validation team who were on fixed term contracts, a lot of them went to secure permanent posts elsewhere. So we have come to a little bit of a standstill on that validation piece. There is a plan to recruit some substantive staff, not to the volumes that we had, but again, Pete and team are leading on that at the Aintree site. And it's also important to note that once the operational planning guidance is issued today, we need to consider the plan around how we reduce the 65 weeks, how we aim to achieve the 65% on RTT and patients waiting under for 18 weeks, as well as balancing the resource required to complete the cleansing work around follow-up. So I am happy to provide a further update at the next board in terms of that plan, but there are many factors here that we have to contend with in terms of just our resource.
Thank you. So thanks, Beth. So on that, I think what we're really looking at is a sort of you've got a failure demand piece here of an overwhelming number of follow-ups in the system, where an awful lot of the time we know patients potentially shouldn't have been referred in the first place, or those follow-ups are a security perhaps because things weren't available or that might have made it a single visit. Some of the work that we're going to be doing on the diagnosis and treatment model will be really helpful here, because that should reduce the overall outpatient burden, which would allow you to start to shrink this. Whereas at the moment, what we're doing is loads of validation and trying to fill on extra capacity, potentially for an area where there's low or no harm, when we've got then queues in other parts of our system like cancer and some of the faster diagnosis work. So we'll come back to the next board with a bit of a view as to how this sits in the context of that planning guidance for next year and what actions we need to take next with that. In terms of the two financial risks, again, we'll cover this throughout the reporting. Rob's obviously updated the risks around the CIP, and you can see where we are, but again, we're going to talk about that in the financial reports. The inability to achieve the financial balance is obviously the risk that we've talked about at board meetings for the last 2 months, and we've got a presentation later on in the private session just about how we approach planning round for this year with that endpoint of the current year, with some further detail in there. I think the frustration for us all, and I reported this to CQC and most recently in our system oversight group to the ICB, is that we can evidence that the organisation's got good financial controls, is managing its money well, is managing its premium pay costs and its vacancies and all the rest of it, but has still got this huge black hole around a failure to meet the new hospital costs. And as we look into next year, again, Rob will cover this in detail later, it's clear that if those new hospital costs were managed, we'd be looking at CIPs in the region of 70, 80 million for Luft, and a similar scale, not similar scale to 80 million, a similar scale to this year, and maybe slightly more for the women's. And if you combine those two, that looks like it's in the art of the possible. If you start adding in criteria to reside numbers and hospital, new hospital costs, it just pushes it to non-deliverable, and every year we're relying on non-recurrent means to get there. So we'll have a much longer conversation about that later, but happy to take any thoughts. They're the key risks, Chair, that we're managing at a corporate level.
You, Mike.
Thank you. It's probably a request for a board development session, so thanks, Beth, for that update. But given the government's pressure on waiting list size, I think it'd be really helpful to understand more about understanding of good waiting list performances in aggregate and in specifics, and what our vulnerabilities on that understanding, and against what our vulnerabilities on our own understanding. Absolutely. So I think it's a really good point that once the planning guidance is out, we were just talking about this briefly this morning. If you look at the sort of levels that are being described, i.e. the faster diagnosis standard of, we think, probably 80%, we're nearly there. If you look at the sort of 65-week performance, It looks like there was a recent bit of modelling done by the provider collaborative who took, basically, if there's no growth, everything stays the same, which trusts would achieve that 5 percentage point reduction, and the only one that got near was us in that modelling. So it sort of feels like with the productivity shift in this last year and further work to do on that next, most of the things that we're hearing are being asked are within touching distance. The overall waiting list is still reducing. So again, not a big problem. It's this thing of how do you manage the what we believe and why we wanted to investigate 100,000 cases of it. The risk around this, everything gets pushed out to achieve these targets, and are we managing the risk correctly? So if we've got when we have a development session, I'm not sure when the next one is going to that would be a really good thing for us to go through the whole picture, I think, because I think we need a documented view of risks. Yeah, that'd be really helpful. Yeah. Thank you.
Yeah, just to reassure Mike, we do also, I think the context of looking at waiting list is really important. So it's a really good point, Mike. And it's not as clear for elective waiting lists, although, like James has just said, we have reduced. We have shown a 10-month sustained improvement on the reduction of our waiting list. So that's really important that we have sustained that throughout last year. But in terms of our cancer waiting list, and for people who we look at that benchmarking as well, for people who have waited 62 days or more to start their treatment, at the moment, we're about 2% under the national average for that waiting list, which is significant for us because we were an outlier in terms of national percentage, but we always, on a weekly basis, look at that national, where do we sit within that? So we look at it for the general, but also we look at it for the cancer waiting list as well. And as I say, we're performing really well against the national average. Thank you.
Can I just clarify something quickly? I'm always conscious when I say the overall waiting list is coming down, which organisation am I talking about? So it has come down significantly at Women's and Loved. So when I was saying the waiting list coming down, it is both organisations that it has reduced significantly.
Okay, thank you. I mean, as you trail, James, the planning guidance, I'm not sure if it's come out while we've been sat here, but being trailed from an acute service point of view, it's no surprise that the priorities are elective care, emergency care, and by the way, make sure you hit your financial duties for doing all of that. But I'll come back to Mike's important point that he raises, which is about the balance of risk on that. We need to try and find a way, I think this year as we go into the planning for next year, to understand the judgments that are having to be made about the line of best fit between all those three things.
Yeah.
And the interaction between them.
So I think this will be the first year we've been able to have that choice, perhaps. In the last year, it's always been, well, we're so far away on everything, we've just got to do everything and get it to a safe level. Yeah. We are at that point now, and it's been made very clear today that the resources are the resources. We expect them to be 1 to 2% less than last year or this year. So in cutting our cloth, how are we managing that risk appropriately? So yeah, absolutely.
On the outpatient follow-up numbers, for a few board meetings, we've got people on this. We've started all of this. I mean, hundreds of thousands, as you described, Beth. So I think it's a significant step forward now that we've worked through at least half of that number. It's the first time that we've had this at the board. What you make about the staff issues around recruitment and retention on the people doing this work is clearly a challenge for us, but hopefully that's a solution that doesn't hold us back. Yeah, for progress. But I think all the way through on that, felt that the sort of, Jim's talked to us about it before, the sort of risk assessment in the way that that process has been done seems to be working well now.
And that validation process is clearly done by validation team people, not clinically risk assessed, but there's no reports of harm. What we're also going to do is take a Datix trawl and look at whether the number of any harm reports through Datix, plus specifically for outpatient follow-ups, has increased or not, just so we can see whether there's a corresponding issue there or not. So we'll do that next time.
Okay, thank you.
Just one important point around that workforce challenge. Matt has kindly got involved in terms of, are there any transformation pieces in terms of validation? And we had a meeting yesterday with an AI company to see whether there are any ways we can have this electronically supported. So I just wanted to make a note for the board that Matt has also given us some support to maybe mitigate those workforce challenges on the administrative validation. So.
Is that the Chinese AI company?
It's not, it's the US one, so.
Just for clarification. Okay, let's move on into the site specific reports, please. And first up today is Peter.
Thank you, Chair. So if the overall the highlight is that there's 11 risks at the entry scoring more than 12, which is the same amount as last. In that, however, there are 4 scoring 13. The same 4 as last month, and I will cover them all in my report. But it's critical care, the ambulance handover risk, the discharge delay risk, and the 65-week risk. There is one new risk, 8478, which is that staffing admin resource risk, which links to the information we've just had about the risk 7915 on the corporate services risk register. That bit for me is the more operational bit of it, where we let that strategic conversation happen at the exec level. And just to give some things, we are trying to prioritise the work as best we can with the staff we've currently got while we have that strategic conversation. That means one risk has reduced. That is the income risk, and I'll come back to that as my risk, and I'll tell you why it's reduced. But that is reduced from 12 to 10 in a month. So we're just going to cover a couple of areas I want to highlight, and we'll cover most of the risks as part of this highlight. I wanted to cover urgent care first. There's 3 risks relating to urgent care at entry at this moment in time. That's risk 6457, 6425, and 8247. As we've been mentioning through the board, there's been continued pressure in the emergency departments all through December and the beginning parts of January. And you can see that on the IPR measures quite clearly. And we'll come back to the specific ones in a second. That led to the declaration of the critical incident, as James has already said, on Monday, the 6th of January. Tuesday, the 7th of January was the peak pressure for entry. And that really links to, as James already said, a big spike in flu cases, both arriving at the ED and being admitted into the hospital. And that's clearly seen in the data. And that was also linked to to a reduction in complex discharge over the Christmas and New Year period. And we saw that on patients. We had trajectories agreed with system partners around patients waiting to go home with social care. We were on trajectories leading up to Christmas, but that fell off trajectory over that period. I think that double whammy was one of the causes of the pressure that we saw in ED on that tube. The particular pressures really that manifest itself, as we discussed, were around ambulance waiting times and also numbers of patients waiting more than 60 minutes in ambulance for handover, and to a certain degree, patients waiting for 12 hours in the department. So just to cover off then, that also links and triangulates to the CQC when they were here and they highlighted ambulance handover as a particular issue. So what actions have we taken around that? So a couple of key actions have been put in place since the last meeting. First is we've opened 2 surge areas, call them surge areas 1 and 2. That offers us another 20 spaces for patients who are in the emergency department. What's really important about this is when you are admitted into one of those surge areas, you are not being treated by our ED clinicians, you're being treated by our acute physicians or the specialty teams. And that helps to decongest the ED. That allows us to cohort into those areas, take patients off the corridor, and importantly, heat free our pit stop area so that we can then offload ambulances straight away. We've also implemented a 2-hour ambulance handover huddle, and we've also pushed on building on this momentum we're doing around our same-day urgent care unit, leading on direct ambulance conveyance for patients who are arriving in ambulances who have already seen a GP or other healthcare practitioner into both acute medicine and frailty assessment areas. As I've mentioned already, we had an agreed trajectory with the system partners in the top, in particular, around our patients waiting to go home with social care. And we sort of had a bit of a dip over the Christmas period, but we're back on track and trying to catch up with that trajectory as we speak. So thankfully, those actions have led to, and I'm just picking up Jackie's point, have led to an improvement on the ambulance handover time. In the week beginning of 13th of January, our average ambulance handover was 40 minutes, which is the best it's been. There's been just a slight slip back since then, but we're still most days running 40, 50 minutes. Some days when there's high ambulance handover, it does creep to an hour, but still really trying to push on those actions. So, but a significant improvement less, and hopefully that will be reflected on the IPR next month. We've also seen reductions in numbers of people waiting for 60 minutes in ambulance, and we've also seen a reduction in the number of patients waiting for 12 hours in the department because of those actions. So that is hopefully showing some, giving some assurance that the actions we're taking are having an impact. Just to also add to the board are aware, Aintree has had some NHS England and North West regional oversight because of the pressures we were experiencing in December around ambulance handovers. Those were initially weekly meetings, they've now moved to 2 weekly meetings. My reading of that, I think, is we provided some assurance in the actions that we are taking, and the focus is now moving much more to the complex discharge end of the issue. Those meetings still continue, and system partners are represented on that meeting as well, along with the HL2 from Aintree. In terms of where we are with the pressures, so you can see in the data, the flu numbers have now reduced, thankfully. So there's less people now attending flu, which is brilliant. However, we are still pressured with complex discharge, particularly patients waiting to go to a nursing or residential home, so-called pathway 3 patients. We are seeing some improvements in the less complex end of that. So when it's relatively straightforward, we're getting you there quicker, but the complex patients in that pathway remain a challenge. And finally, just some positives on ED. James has already mentioned some of these, but despite all that pressure, Aintree has maintained 15-minute triage. Actually, we've seen a above statistical process limit improvement in 60-minute treatment. So that is statistically a significant improvement, and I think that is linked to some of those actions we have taken. So the ED team themselves have managed this pressure extremely well. And we've also seen in December an improvement in the friends and family test in the ED, and that's also really good. So I think that triangulates with some of the stuff that the CQC mentioned to us when they were here, that actually patients felt they were being well cared for in our ED. I do also think that some of that links to the opening of our same-day urgent care unit, is getting patients out of the ED into an area appropriate for them. I just want to cover the 65-week wait issue, which is risk 8266. Beth's already mentioned it. This is really specific for Aintree around the head and neck service. There's 2 bits. That is the ENT part of that and the maxillary facial unit part of it. Both are slightly different reasons. The MFU issue, the maxillary facial unit issue, is much more resilience and recruitment of consultants into a really hard-pressed specialty. That links to the risk you see on our risk register of 7530. But the ENT risk is just pure capacity demand, as Beth has already said. And the actions in MFU is really, we've agreed with the consultants to undertake some waiting list initiatives, and we're getting back on track with that. And the ENT, as Beth already said, we're using an outsourcing company to do some outpatients. Hopefully we're making some progress into that. Just to give some assurance, we're going to include both these areas into the 25-26 Aintree improvement plan, because I think we need some transformational change to really make a difference in those areas. We're going to cover the finances, right? So there's 2 risks there, 8204 and 8203, CIP and expenditure. Monthly position for Aintree on finances was that year to date, we're 10.4 million behind plan, but month 9 is essentially break even. Income, month 9 was 2.5 million better than plan, taking us to year to date better than plan of 7.5 million. So that's why I've reduced that particular risk to 10. Pay, we've seen we've maintained the improved position I've been talking about over the last few months. There were 0.1 million overspent last month, so the year-to-date position remains around 6.6 million. Non-pay remains a challenge. We were overspent by 1.5 million in month 9. 0.6 million of that was fees for consumables, and there's a specific piece of work going on for the surgical division to look into improving that. And we are seeing improvement in that position. CIP, in month we delivered 2.7 million against our 3.1 million target. That takes us to a year-to-date position of 20.3 million, which is approximately 5 million behind where we should be. But what's really important, what's helpful and potentially positive in month 9 in the entry is the improvement in the current position in CIP now to 15.6 million. So that is a significant improvement from where we were last month. Just a couple of specific risks. The critical care risk, as I've already mentioned, remains 13. We have agreed through the HMB some short-term measures now about flexibility in our use of critical care beds to get us through winter. There's a longer-term plan now coming together, and both Rob and I are taking some meetings with the ICB from a financial aspect and a clinical aspect with the ICB to look into how we can right-size the critical care if possible. So those meetings will now be taking place in the next few weeks. I just want to give some assurance on risk 8542, which is the surgical in-reach risk. That should come down now in a month because Nat and I have agreed a standard operating procedure for the surgical in-reach from the Royal into entry, and I'm assured that that will now be in place, and that should bring that risk down next month. Just going to bring out a couple of points then I haven't mentioned that are relevant on the IPR. James has already mentioned it was the CDT, the C. diff risk at entry. We have seen an increase of 16 in month. That is again above the upper statistic process limit, so it is significant. 13 were hospital acquired and 3 were community acquired. As James already said, that does seem to be a national trend, unfortunately, but we are looking at every one of those cases and looking for lessons learned. I'm seeing a report back through quality and safety next month. And then also just to mention the sickness absence, that's another the IPR have had an increase to 7.3% sickness absence in December, and again that's above the limit, so it is statistically significant. That is, as James has already said, actually short-term sickness with flu, but also there is an underlying issue with the long-term sickness with breasts, etc. And we are working with the people in the OD team to see what actions can be taken and report coming back. And I just want to finish now with the specific actions, because the question's been asked in the board this morning about what specific actions are we taking in the entry around CQC. And so the ambulance handover issue was raised, as you can see that in the letter, and I think I've covered that. The issue around ED holding all the risk and the 12-hour in department risk that the CQC rightly highlighted to us, I think it's been managed through our use of continuous flow and boarding, which is improving at entry. There is a cultural piece that sits behind that, so there's a how do we do it piece, but there's also a cultural piece that's sitting behind that. ESIST have been helping us with some meetings with our senior nursing team around that, and we're also using the evaluation plan collaborative. We are focusing through the entry urgent care improvement programme on really focusing on those basic ward processes as well to help with that flow and taking the pressure off. The Surge 1 and Surge 2, as I've already mentioned, an important piece there about decongesting and taking the pressure off ED is that those areas are not being managed by ED, being managed by other areas. So that's helping take the pressure off the emergency department team. Finally, we have opened our entry reablement ward, which is Ward 17, which is our redesignation of that ward, which is really developing a pull culture, and I want them to come in, and that's making a big difference to the ED, pulling patients out of ED with physio and trying to get them home. I was up there last month. The team were doing really well in demonstrating the value they can add, and I'm going to get them to come and speak to the Value and Patient Time collaborative. The SDEC risk, absolutely, CQC were right to raise this. This is a work in progress for us. We're working with ESIST. Becky Hanlon, my medical director, is leading on that. There's been further meetings with the acute physicians, and we're trying to enact that plan and really trying to speed it up as much as we can. And then the transfer of patients into ED who could go elsewhere, really for us is focusing on NOFU and the surgical assessment area, but the patients essentially that really don't need to come into ED and they can go directly to the right area. So that is a conversation we're having with the surgical division. Now, if I just pick up some of the medicine stuff, the medicine inspection stuff, the issues that are highlighted in that were the conscious sedation policy that has now been written. It's due to come through QSG, Quality Safety Group, in February, I think. But in the meantime, we have got messages out through both the senior nursing and senior medical forums to say this is really the number of actions you have to take, and hopefully we're seeing some improvements in that. There was an issue with prescription pads, which were the outpatient prescription pads that hadn't been properly locked away all the time. Just basically a message out that those are now all locked away, and we have had some spot checks and they are. And then there was the issue, finally for me, on the use of the discharge lounge and bedding of that. That all links into Surge 1, Surge 2 type stuff. So that's all part of that plan. So each one of those has an action against it, and I will report into my urgent care floor group. I'll pause there.
Thank you, Pete. So just to say, on the ambulance handover side of things, this is one of those questions where I'm talking about a chart that none of you've got because it's on my light report system.
Always help.
No, but you can witness there it is. So since the sort of 8th of Jan or roughly then, for the previous sort of 70 days, Aintree had long ambulance handovers above the mean 6 out of every 7 days. And since that changed, 17 out of 18 days has been below. So massive statistic, you see it plain as day, there's a significant change. Is that, in your view, the Surge 1 and 2 outflow that's just allowed that to?
In part, James, I think, so Surge 1 and Surge 2 are really critical to that. And how we manage that is we would sort of reverse cohort into those areas when we get pressure, so the department doesn't clog up. And that crucially really helps us keep that pit stop area free, so then we can then get ambulances off and into that pit stop area, which is what it's supposed to be. So that's how that works. But also, just really careful management of that ambulance arrival, and then the 2 hourly ambulance huddles we're having also helps.
About the HAS screen.
Yeah, and a slight addiction to HAS screen, unfortunately for me.
I mean, you can see really clearly in the data that it's had a big impact. Really
yeah, I think we were running an hour and a half, unfortunately, early December. 40 minutes really is the
very encouraging. Well, Jackie, have you anything else you wanted to follow up on the handover?
So I suppose my bit was around the handovers and just making sure that when they have taken an extra length of time from the ambulance into the department, that we haven't got any patient harms that are as a consequence of that. And I just wondered if you had any sort of information on that.
So I haven't got any specific information on harm, nothing certainly significant harm, Jackie. We will look through the clinical effectiveness committee. Is there any other harm that's been associated? But there's no significant harm that has been reported through the DATEC system.
Yeah, I was just interested because there's been a lot in the media, hasn't there, about the harms of patients staying on ambulances. So I just wanted to make sure that we were on to looking into it as well.
Yes, and obviously we know that time in ED department, particularly in ambulances, does create harm, and so we do constantly look at that. Yeah.
Other points for Peter, please.
Right. This is going to sound discouraging. It's not meant to. If you can no criteria for design point, really. If you look at the data, the last 2 or 3 years, no significant change in the number of people attending. And the last 2 years, no significant change in 12 hours, 15 minutes, blah, blah, blah. So there's that sense, and that's after all the innovations like the TOC and the Sudoku and the stroke and now Surge 1 and 2. We do all this stuff. Is it simply that we just don't have enough beds? Is there any, in terms of shifting it from that really difficult structural position into something different, are there any innovations left to us that we haven't tried on that kind of incremental continuous improvement basis?
I mean, there's always stuff we can do, Mike, in that front door bit, and we keep innovating and adding more, as you say. I think where you started, I think, was the no criteria design, and that does remain a frustratingly static position. So I think there is things we can do around that, and there's conversations going on between us and colleagues about how maybe if we took more control of managing the discharge process, would that assist in a better way? So those conditions are live at the minute, and I think that might be the way, because it is. If you just look at the critical, the sort of early January, it was a 2-pronged attack. Really, there was the increase in arrivals was a fluke, plus the sort of delayed discharge piece. The front piece we've sorted. The delayed discharge piece, whilst improving, isn't improving at a rate that we need to help us.
James,
I think the reality of where we are now, I think, is
demonstrable in the fact that we've got the things that we were able to control within the organisation. So the big issue when we had a year ago a report from Newton that talks about we were over-prescribing pathway 3 care for people who might need care homes. And we've seen a significant reduction in that. So that's, you know, us managing to not put people down the wrong pathway and instead shift more people to pathway 1 and 2. So that's good. What we're also starting to see, but it's very early days, is the brokerage system in the council now is delivering on those care homes or that pathway 3 support quicker than it was, and the numbers are coming down. What we've then got is our problem is we've got, and that Bill know the numbers better than me, but probably every day, what, 80, 90 pathway 1s or more than that?
Yeah. Double that.
Double that. So 180-ish. So that's about half of our delayed discharge cohort are in the easiest pathway, need something simple. Our understanding is that the people who provide those things, whether that's home checks or key safes or house cleans, have got capacity, but the bit in the middle isn't working. So we're doing our bit of getting that discharge early, the bit in the middle isn't working. And that's back to the concept that are, again, live this week about, look, we've now given the 6 months of all working together on these 3 separate parts. The 2 either side are working, the one in the middle isn't. Do we need to have a conversation about how that's delivered? It isn't within our control, but it possibly needs to be.
Yeah, and just the numbers on that, like, so in mid-December, those pathway 1 patients in the entry, if you look at all our areas, all 3 of them, we were about 70, 80. We had a trajectory just before Christmas when we really split that middle bit that James talks right? And we got down to this, but then in the Christmas period, we were back up. Coming back down again now, but it's the constant focus on that middle bit that needs attention.
Just one quick question. In relation to risk 7032 around critical care, I just wondered, has that meeting with the ICB to review how many beds are commissioned, has that taken place? Or if not, is there anything else that we need to do given how long this has been a risk within the Aintree site?
So it hasn't taken place yet, Daniel, but there's 2 dates I need to respond to when I do in mid-February. So it's due to take place, I think 14th and 17th of dates. I don't think I can do them, so we'll find a date around then. So that's the first bit. The second bit really is the bit that I'm doing around flexibility. And we have agreed something through the HMB about how we can use this, the winter funds that we have just to be flexible when we need the extra pressure on the care situations are coming. And that is keeping things in a static position at least. So there's no harm because of that flexibility. But the bigger picture is what is the long-term future of critical care, and that's a conversation I'm hoping will happen in February.
Did critical care capacity in the trust increase in the COVID period, and have we maintained that level since?
Wasn't increased. We've obviously moved hospitals as well since then. So the during the COVID period, everybody sort of expanded their facilities into other areas, didn't they? And I wasn't here at the time, but I was involved at the ICB level, and I remember because this organisation had significant CPAP facilities and things. But the number of critical care beds hasn't changed. We've moved into a new build. What's changed slightly is the split of the pressure, where the pressures sit, because previously you had the Royal had X, Aintree had Y, but then services like vascular and other things moved across sites. So that adjustment has been challenging, let's say, to get agreed over the last few months.
Okay. Any other questions? On the Studium difficile cases, this has emerged over the past 2 or 3 meetings. Jim or David, I just wonder if there's any system-wide discussions to try and, you say, we're reviewing the case, the hospital-acquired cases. Anything that we've learned from others about why this is happening?
Indeed, so we know that within Cheshire Merseyside and the North West that the numbers of C difficile cases within the community have significantly increased as well. So it's unsurprising that our numbers have increased. What we've done is we've tried. We have looked at where do we sit against other organisations, and where do we sit in that mean average? And for a C difficile, we still sit on the average for Cheshire Merseyside and the North West. That's not to say that our numbers haven't increased, because they have, and we need to continue to take every effort but it does indicate that in the wider system, there's a greater number of community acquired infections.
It's worrying, this, isn't it?
It is, and we sort of asked the other day, because the way the data is presented and understand it in a sort of consistent way actually doesn't distinguish between community acquired and hospital acquired, which used to be the great differentiator. So a number of these cases are coming into hospital with seeded already. So yeah, it's perplexing at the moment to try and figure out exactly what's going on. Jim's got the answer.
Well, I haven't got the answer, I'm afraid, but I thought you might want some assurance about antibiotic prescribing in relation to DIF. And you know that we've done a lot of work on changing the antibiotic formulary and indeed taking out the use of some broad spectrum antibiotics that are both very expensive, temacillin being one example, and also linked broad spectrum antibiotics are often linked to type of secondary infections. So the microbiologists have been going back through the cases to see whether there is a link to our antibiotic formulary and our changes, and we can't see that there is a link. So that's giving us some assurance that we're going to stick to our guns on the formulary as we've got it, and push heavily, of course, on the intravenous to oral switches as well, which we're improving on and helps. Jackie's rightly reminds me about bare below the elbow. And the evidence around hand washing and bare below the elbow. We've certainly been messaging to all our clinical staff, reiterating that, and I know David's doing hand washing audits and so forth to check across the system as well.
Thank you. Okay, all good. Thank you, Peter. Royal, Natalie, please.
Yeah, okay. So I won't go back over everything with the critical incident, but just to touch on from a Royal perspective, there are 4 risks at 12 and above that are related to urgent and emergency care. A couple of them have been escalated. They were on the risk register previously. They've been re-escalated in monthly score due to the pressures we've seen. So you can see in the IPR, again, similar to Aintree, we had significant increase in average time for ambulance handover and handovers over 60 minutes. And we've talked about the flu and the pressure we had at the beginning of January. What I would say is we've used both the CQC feedback and the critical incident to do a debrief with the teams, and we met last week through our UEC governance at site, which is the Right Patient Right Team Forum that I chair, and we have reviewed our work streams to refresh whether we have got the right work streams or need to stand up new ones. One of the key things that came from the CQC visit at the Royal was around the ambulatory majors area. So for those that aren't as familiar with it, that is the area that in the CQC visit, it discusses that was a very busy area, and it has a number of seated things within it. So we do have patients at times of pressure who are waiting longer than we would want in a seated area, and there is difficulties with patients' privacy and dignity within that area. So what we have done is we have agreed with ESIST. We believe there are patients there who could be more appropriately looked after within our same-day emergency care unit. We've identified an AMU and an ED clinical lead who are going to work with ESIST, and we are going to look at to see how we could get the pathways direct to SDEC, and then the plan will be to physically turn that area into 2 additional majors cubicles as well. So we need to do it hand in hand because we can't change the estate unless we change the clinical pathways, but we have started that work, so I will be able to report back in the coming weeks on the progress with that. What I would say just on the ambulance data, so from the 7th of January when we stood down the incident, we've only had 50 over 60 minutes. If you compare that to over 530 for the month of December, we've had a significant reduction. The Royal is also now at an average ambulance handover time of 29 minutes, which is the best we've had it in over 18 months. So I suppose it's a bit contrasted to the critical incident, but we have seen significant improvement in recent weeks at the Royal. We also, as part of the incident, stood up 3 times a week meetings with system partners that I chaired, and we've continued those. I've just done one this morning again. And I think picking up on some of the discharge points, that's been really beneficial for us to try and understand where some of those blockages are on an operational sort of day-to-day basis and manage those. Just to touch on Jackie a bit around patient harm question. So what I would say is that at the Royal, when we declared the critical incident on the Monday, the ED consultants were raising concerns around patients in the ambulances and the potential of patient harm, and that was part of the decision making of declaring the critical incident. I suppose what I just need to make clear is when we have ambulance handover delays of 60 minutes plus at the Royal, generally they are not in the back of ambulances. We bring them into the department, and that is why we have the corridor, which I'll come on to, the corridor issue, because the team have the ethos of managing the risk and bringing the patients in. So generally, whilst the crew might still be with the patients, we are sighted on those patients and they are in the ED department. So the next bit from a CQC perspective was the use of the temporary escalation spaces. That generally is the main corridor next to the running alongside the emergency department. Again, since critical incident stood down, we've had a week where we had no corridor patients, and generally that has been 10 or below for the recent weeks. I suppose just coming back to the not meeting criteria to reside point though, we don't want corridor care, and the whole UEC improvement programme is to remove it, but until the bed occupancy improve, levels drop in the hostel, I think I'm going to be limited in what we can do around that corridor care. So really it is driving through that health and social care improvement plan, which is going to help me reduce corridor care. The other bit I'll just touch on for UEC. So we've talked previously that we relocated the walk-in centre to over across the road from the ED last winter. We successfully, from the 16th of December, have now got primary care streaming 7 days a week in that centre. And we are aiming within 2 weeks to have that 24 hours a day as well. We've worked with the ICB around getting the out of hours provision also over there. We reviewed that data yesterday. We're seeing positive utilisation of that, and we're hoping to build on that and work with the ICB to look at potential and urgent treatment centre provision co-located to the Royal ED. So the other risk around UEC is mental health that remains as a 12. Again, in the recent week in particular, we have seen increased lengths of stays in the mental health hub while patients are awaiting discharge or transfer. We have done various improvements with working with Merseycare, but we have agreed now, I met with the Director of Mental Health for Merseycare last week, and we have agreed we are going to bring a new work stream into Right Patient Right Team with the Directors of Nursing to look at the next stage of improvement, and particularly around provision for those long waiting patients in that mental health hub. So that will be a focus for us over the coming weeks. Just moving on to other risks. So we've talked about these previously, but there's two risks that have escalated for dental workforce that are on the risk register. The reason they have escalated is because one of the consultants we expected to appoint hasn't accepted the offer, and the other one is we've got some unexpected sickness absence that has occurred in December. So we are working through with the team. You can see in my narrative there are mitigations in place, and I'm meeting the dental team tomorrow to see where we are against that plan, but that's just an ongoing challenge really with the fragile services within the dental specialties. The other risks I would just touch on is there is the risk still remaining around the DMO1 standard at the Royal. If you remember, this was around the endoscopy capacity. Being the IPR at 9.1%, so away from the 5% standard. I have reviewed with the team though, and we are on track with the trajectory to be back at meeting the target at the end of March. So we will wait until the end of January data, and then I would expect that risk to reduce if we've met trajectory again. There is also a risk remaining around urology demand and capacity, and particularly for the follow-up outpatients in urology. Urology has significantly overachieved its activity and income planning month, and the division have formulated a business case that is coming to HMB this month, which will look at an investment in urology to provide additional capacity at a cheaper option than the ad hoc insourcing that we've been previously reliant on using. Once we approve that business case and get the recruitment again, I would expect that risk to reduce. And then just moving on to finances, which are the other risks at a 12 plus. So from a Royal perspective, as we discussed previously, we've seen continued overachievement against the income plan. We're 15 million over recovered year to date. Generally, our income and expenditure from an operating perspective is aligned. The main issue at the Royal is around the CIP. So we are 6.7 million year to date over spent. That is an improvement in month, but our CIP was 39.5 million for the year, and we're forecasting to hit about 25 million recurrently. So that is our significant focus, and clearly that will impact on next year's plan, that non-recurrent achievement. We're working through the teams at the minute around the plans for next year and the delivery from April, but that is the key focus at the Royal. And then just finally, decisions made. So we did have a business case brought forward from Paola's team around introducing the Citizens Advice Bureau. Again, this will be part of our UTC at the Royal and how we support patients when they present with social or other issues. We couldn't approve it at HMB due to the financial impact of that, but that has since gone to execs, and we have a plan and now picking up with our ICB and system partners of how we could support that development, which I think would be a really positive way forward for patients and staff at the Royal, and looking at how we do that across all sites. So that will be picked up at the future exec meeting. I think just on performance metrics, sorry, there were two just to point out. So from an elective, sorry, I've missed the main issue. Sorry, there is another issue. So elective and cancer. So the significant issue for us, electives, we only had 165-week wait breach, which was patient choice in the month of December. So from a Royal perspective, the elective side of things feels positive. We are more challenged around the cancer and when we talk about the FDS standard. So at the Royal, as I've discussed last month, we had a risk around breast FDS. This is largely due to a radiology input into the breast service, a mixture of vacancies and long-term sickness absence. We agreed a plan to insource, but that didn't come to fruition in December, and the FDS standard has significantly deteriorated. We have also seen a significant increase of nearly 100 referrals a week, above the usual average from the 15th of December for the last 5-6 weeks into that service. So when you combine the capacity reduction with that increase in referrals, we've got a significant issue in breast. I've met with the team and Beth has supported me in coming up with an action plan. So we are reaching out for mutual aid and we are working with the Cancer Alliance to look at what we can do to support. And I have got a weekly review meeting in with the divisions, which will take place next week to see how we are progressing against the actions. So that just flagging that is an ongoing risk, but I'll have a better view on that next week once we've actions with partners. On the IPR, the only metrics other than we've picked up on to raise were around, you can see session utilisation in theatres has statistically dropped in December. Just to say that is due to the planned stand down of elective activity around the Christmas period. And the other one, we've had 5 data points on e-news that have dropped from the target. So I've asked for that to be specifically looked at through quality and safety next month, just to give assurance of how we are keeping on top of that and an improvement trajectory.
Thank you. Points, question? Excellent. Yes,
just one comment. So I had the privilege of doing my first walk round of the Royal earlier this month, and I did the ED ambulatory, and to echo your observations, Jeffrey, blown away by the attitude of the staff and just how passionate they were, how much they loved what they were doing. The day that I was there was a few patients that were in the corridor, but you could see the care that was, and it didn't feel like it was a last resort and they felt inconvenienced. It was just from brilliant. So I was really blown away by the staff and how they managed everything in there during still like a really difficult period. So
thanks, Sarah. Great to see you. On the Citizen Advice Bureau business case. So we say it would contribute to prevention of admissions and ED attendance. And in the context of what we described, if there's compelling evidence of that, then my assumption would be that even from a business point of view, that's a no-brainer in terms of moving forward at the payback in all of that. Why are we faffing about with it?
Right, okay. So, there's no doubt that Citizens Advice Bureau delivered in the way that we would like to see it. So there's 2 models that are available. One is the ability to refer a patient directly to a citizen's advice or a phone call 48 hours later. That's the cheap option, 60 grand a year, something like that for one site. Doesn't feel to us like that's going to have the biggest benefit, or that people actually might follow that up. If you have a located Citizens Advice Bureau in the building that is open, then it's available for people to make their own choice. It's available for people to be referred to, but it's also available to staff. And what we've seen, because we've done this at overhead, is significant improvement in both staff sickness, well-being, because all of our staff are in similar situations to our patients in terms of current economic environment, everything else. And then a real benefit for the patients. The cost of doing that's about £200,000 a year. So we're sitting here on the one hand saying, right, that's something we really need to do. But to do that at Aintree and the Royal, question mark for Green as well, is, you get on for 400,000 to 600,000. We're also in another room saying we can't afford validators to go through the waiting list. We can't. So this is the dynamic. Now, we're not going to leave it there because the evidence, it's been researched, the evidence is clear. So this is a conversation now for the place team around things like the Better Care Fund. This is exactly what the Better Care Fund is designed for, placement is designed for. So Rob's in conversation with both the place team on that perspective. We also want to have the conversation with the LASP organisations, because if you were to put one in Aintree and the Royal, it could be available to Clatterbridge and Walton. And if everybody looks at this together, 200 grand is not a huge amount of money for the benefit we get. So we're going to find a way, but at the same time, we've put freezes on things for staff to just then go and fund things without any understanding of how we're going to get the money back in. It's right. Given the challenges we've put on other people. So it will get resolved, I'm confident, just about finding the money.
Chair, and just the third stream, we're just investigating. You'll hear from Paul and Nicola later about our social responsibility and our green plan. Lots of our suppliers who have funds available for social responsibility. So we're going to be pursuing that as not leaving any stone unturned. Thank you. Any other points, Royal? Okay, well done. Jenny, please.
Thank you, Chair. So at the government, we've got 5 risks reported, 12 and above for the board, which is the same number as last month. There are no changes in those risks in the scores as articulated. We do expect some movement at month 10 following some rigorous discussions at the Hospital Management Board this month. There are 2 risks in relation to anaesthetics, 2770 in relation to the cover for out of our emergencies, and 2842 specifically the cover for delivery suite. We have come some way in covering the on-call rotas with both speciality doctors and consultants, but we are doing more work with Luft in terms of how we can shore up those anaesthetic rotas across both sites, and that work is ongoing. We expect that work will form part of our improvement and transformation work stream going into 25-26, and it's also addressing some of the medium-term risks to the services that we've seen through the Women's Services Programme Board that were identified some 12 to 18 months ago. So as we work through those plans and those controls are updated, we'll see those risks likely be re-articulated in that context. Picking up the risk on pharmacy 2764, again, the risk remains unchanged, but to note that we did discuss in detail at Hospital Management Board a number of additional risks that were articulated as part of this, and a business case has been completed in terms of proposed structures and solutions. It will be reviewed initially by the hospital leadership team next week, and then the Hospital Management Board. And again, the solutions that are set out in that are likely to form part of next year's transformation plan, be it at a site or group level as we take that forward. I also want to draw out the risk around the delays in induction of labour on the report. We have been reviewing the effectiveness and sustainability of the controls in place and being undertaken by the Family Health Division around delays in inductions of labour, and we can see that we're green in terms of where we're sitting across the region. But as an organisation, we do have an ambition for no delays, so it's where we sit through that and really reviewing in the context of our ambitions versus where we're sitting across the organisation and in the system. We did see a bit of a spike in December with some higher sickness and acuity and attendances. To James's point earlier on, we will be performing a read across other sites and the corporate risks to make sure that Liverpool women's risks are aligned from the 1st of April, and that we're looking at those in the context. The other risk on the report above 12 is the neonatal service delivery over 2 sites, so ourselves at Liverpool and Alder Hay. We will be looking to de-escalate this risk. We can see the partnership working well in practical terms, and while we're continuing to keep things under review, particularly in relation to governance, the service itself and the progression of the new unit that's being built over at Alder Hay for the surgical babies to remain over there in their dedicated unit. It's likely that we will look to reduce this risk. We will report back next period. So moving on to the financial position at month 9, you'll recall Liverpool Women's has a planned deficit of 11.6 million, which we are on target to achieve. During the course of the year, we did receive an extra 16.9 million in additional funding from the ICB, which has reduced that deficit target for the year. But as we've noticed in previous months, that is supported by non-recurrent items, particularly within the cost improvement programme. So the cost improvement programme for the year for Liverpool Women's is 5.9 million, and that is planned for delivery, but only 2.3 million of that cost improvement plan is recurrent, and that causes an issue as we move into next year. I reported in my paper that we were behind the full year capital plan at month 9, but we have addressed this in terms of getting some rigour behind the schemes, predominantly the existing schemes that were on the plan for the year, rather than introducing new schemes or bringing schemes forward. And I'll note further in the paper the intention to progress with a digital infrastructure programme, which will contribute to the use of that capital as well. Unhappy to report that the additional 1 million that we bid for against the ambulatory, we found out a day or so ago, was not successful, which is disappointing. We would have struggled, in all honesty, to spend the whole of the £1 million within 8 weeks before the year end, which would have come with that, but it would have helped us smooth the capital programme into future years. But that would be unsuccessful bid. I've not had the feedback as to exactly why yet, but I know it wasn't successful. Just to note on cash, as you'll recall, Liverpool Women's has drawn down £7 million worth of central support during this financial year. We did expect to require more, but with the 16.9 million that we received in additional funding and some really stringent cash management, we don't expect to require any further cash into the organisation for the rest of the year. But what we do have is a significant underlying deficit, which remains, and that is reflected in our back risk and our long-term sustainability. So moving on to performance, we do have a positive position in terms of our waiters in excess of 65 weeks, which was 0 at month 9 and expected to be maintained for month 10. We've noted the 28-day cancer faster diagnosis standards, which has improved above our trajectory, and that's at 72.9% for month 9. And whilst our 62 days referral to treatment target is above our own targets, we know it's notably low at 45.2%. And gynaecology itself nationally is low in terms of performance, and we do have some specific challenges as a tertiary centre, but we are challenging ourselves around what we can do to improve that, and working with the corporate ops team to get that up in 25, 26. That must remain a challenge. One of the areas we discussed through the meeting was around theatre utilisation. That's been an area of focus for us, but we know that there's more that we can do. Again, stitching in with the corporate ops team and some of the work that's been going on centrally at Luft, which we think will really help get us even better than we are doing. I do also want to flag a Never event, which is not reported in the numbers. So we reported 4 at month 9. We had another one during January, so it's not in the numbers, but I just want to flag that now because we're aware of this. That will take us to 5. It was reported as no harm. It was the use of a coil, but it was the wrong coil that was consented for that was used in the procedure. So we had done a thematic review on the 4 that had occurred so far. Again, all no harm, more around local procedures and individual practice. But again, with this 5th one for Liverpool Women, that is a large number for us. So again, we are looking to get some support in from Luft through the Director of Patient Safety, just to give us a fresh eyes on the work that we're doing, the thematic reviews, and making sure that there's nothing more that we can do. Moving on to CNST, we did approve that here at the board last month. So we set out the next steps that we need to get that submitted to the ICB, and we did report for compliance. We reviewed the perinatal dashboard, which is here today. And finally, we also approved a digital infrastructure business case with preferred option to align with Luft's infrastructure. There were 3 options, and we're reporting that through our group senior management board for awareness. And as I mentioned, some of that capital will come out of this year's plan. You'll see in the report the decisions that we made, and I'll take any questions from you.
Thank you. Jenny, with the maternity incentive scheme and prenatal surveillance to come on the agenda in a short while, any other, James?
Yeah, we have more a comment that there's a risk the board is around pharmacy and some of the resources around pharmacy. It's also a risk of the Royal, it's a risk of Aintree, it's a risk of Walton. Now that there's a connection here in that we all have the same chief pharmacist, that as she's sort of exploring where we sit in the sort of benchmarking, it feels like it's under-resourced. You'll know Luft has put money into that over the last year significantly and seen benefit from doing that. So we're just going to have a meeting to try and have that conversation more in that last space of the 5 trusts, because what we're seeing is sort of incremental asks across the system rather than a whole system look at what should we do with this challenge that we've got around pharmacy resources. So Jim and myself are going to meet with the chief pharmacist and have that conversation in context on that. So it's sat in risk registers. We're just mindful of multiple separate business cases versus a sort of more structured overall plan. Okay, thank you. Good. Yeah, Dan.
Jenny, I just wondered in relation to the capital expenditure and where we are, whilst you say you've got plans in place, is that something that's on the risk register? Because obviously it wasn't registered as a significant risk, but I wondered whether it needed to be flagged, or if it's not, does it need to be? And then in relation to the CIP, I could see in month 8 there was a 0.3 million improvement in the recurrent, and I just wondered how that has gone on within the finance and performance group to improve the position, whether there's an up-to-date position.
Yeah. So take your second question first. There is a fortnightly CIP portfolio board, which is trying its best to take as much of the 24-25 CIP to the position. As you say, it moved on by 0.3. It's not moved on that much more, Daniel. Particularly as we are currently working up the 25-26 CIP challenge, which we need to have in place moving forward into the new financial year. So I don't expect that figure to improve significantly from a recurrent point from 24-25 as we focus in on 25-26. We haven't got a high risk in relation to the capital expenditure at the moment. We will keep that under review. We know that the capital pot for the performance is incredibly small, so any slippage, we would lose, which would then impact us into future years. But as it stands at the moment, the schemes, as predominantly already existing schemes, carry lower risk than if we were scrambling to get new schemes to fill the pot. So it's not, but we'll keep it under review.
Mike. Thank you. Thanks, Jenny. Can I just understand the rise of patient safety investigation? Is that about improving reporting culture or deteriorating performance?
So it's a relatively new way of reporting incidents, and we find at Liverpool Women's that we're probably an outlier in terms of the number that we reported to SIIs. We have seen a drop actually in the number moving forward, and we're awaiting some more guidance around specifically maternity and how we're reporting there, because we do have a lot of other sort of things that we need to factor in as we're reporting that. So it's not necessarily that we are. It's an issue for us, but we do report more than other organisations. So we've got that under review, and we are waiting for the new guidance to come out.
Okay, thank you. David.
Thank you, Chair. You mentioned the delayed inductions at our last meeting and said that there were harm reviews done. Is that process continuing?
It does, yeah. So every time there is a delay in induction of labour, it's a midwifery red flag and it's flagged as an incident, and each of those incidents is reviewed by the head of midwifery.
Thank you. I had the pleasure being taken around the neonatal unit by Chris the other week, and it's fabulous, fabulous facility. And he mentioned, as you've just mentioned, the shared unit being opened at Alder Hay. Is there a time frame for that coming on stream?
I don't have that timescale at the moment. Sorry, I don't know if you.
I can't remember it is, I thought it was towards the end of this year, the build concludes. And
Yeah.
there'll be an ops commissioning, but it's
It's underway.
Builders still on site.
Yeah, it's underway. It is being built at the moment, but I don't know.
Great facility.
Yes.
Thank you.
Jackie.
Yeah, so I was going to wait until we actually got to the perinatal dashboard and the maternity incentive scheme, but as David has brought up the induction of labour, that was the focus of our maternity safety champion walk around a couple of weeks ago, and we could see improvements that were being made, so we know where we're going. There was some issue we brought up around the actual timeliness of inputting that data. There seemed to be a collection of data and then a big input rather than it being done in a timely way. And I think that's really important, and we addressed that. But we did follow the patient's pathway, and it was much improved from what it was. So.
Okay, thank you. It's unfair for me to raise this sort of CIP, recurring, non-recurring, but those got all sides are struggling. Or a recurring number of 2 million. We've still got your report to come, Rob, but I just wonder if there's something in that sounds outrageously unfair, and I don't mean it to take the point. If we can identify a lot of non-recurring stuff for this year, it just avoids us making more difficult decisions about recurring savings. All we do, we're just making ourselves bigger problems for future years. And I worry about what we discussed it plenty of times, James. 2 million recurring savings. I think that I thought we'd be able to do in a couple of hours meeting.
Yeah, one of the issues we have at Liverpool Women's is we were one of the first organisations to go into deficit because of the underlying position around maternity tariff, the isolated sites, and some of the issues we've had around the wraparound. So in terms of CIP identification and delivery over the last sort of 5 or 10 years, we've probably exceeded other organisations in previous years, and we're down to the real bare bones now, particularly when you think about the investments that we need to make in maternity and care-based sites as well. So it is an incredibly difficult challenge, and we challenge ourselves each year.
Perhaps you could pick this up in your report, Rob, when we there's a better way of
Maybe if we can just consider.
Yes, sir.
It's been an ongoing topic in our finance. Obviously, we've been no longer part of. I think one of the things that, and certainly Tracy had challenged on, that maybe we do need to unpack more broadly is, with the focus so much in year, and we're finding that continual misbalance between recurrent and non-recurrent. Actually, where do we get to the position where we're bolder in the investments near term to deliver the recurrent savings over the longer term, and are we actually mortgaging some of those longer term recurrent opportunities, similar to the citizens' advice, there's longer term returns there, but shorter term. So I think that's maybe something that we just need to explore.
Yeah. Just this very much like the faster diagnosis performance and other things is the problem for Liverpool Women's is obviously having a small number of specialties being looked at as an individual organisation means you've got this problem of, Liverpool Women's is getting on the list of a site that can't deliver a faster diagnosis standard or a cancer standard of X. But to do it, you would need to double the national average for that specialty, which is just unheard of. And it's similar with the money. This morning, the health secretary was very clear, as was the NHS CEO, that quality and safety standards in maternity must be protected. So again, if you're sitting in a larger organisation or a larger cohort of organisations, you'd be taking judgments, wouldn't you, about which bits of your organisation you need to protect or treat differently to others. I mean, you just can't be just left with this, but all the targets are the same, all the asks are the same. So it's going to be interesting to see what maternity services being protected is going to look like, because they certainly haven't been in terms of requirement for efficiencies. But my hope was that they particularly picked out maternity service standards from a quality and safety perspective. So it might give us some hope for this next year.
Yeah. Okay. Thank you. Clinical laboratories. Yes, thank you.
Oh, no, sorry, I've got the order wrong. Sorry, not trying to confuse everybody.
So,
Broad green, sorry, Natalie.
yeah, there's no risk 12 plus at the minute for Broad Green. Just two things I would raise. So we've touched on the sickness absence that continues to be high at Broad Green. I suppose from coming in as the executive on that side, I'm assured around the sickness absence policy and management. What I think I've asked the team to look at is the number one reason is personal stress and anxiety outside of work for staff. So we're going to be looking and linking in with the corporate OD team around what is our offer to staff at Broad Green. Is there anything we're missing that we could be supporting further with? The other bit for Broad Green is the finances. So we are we are better than planned so far this year, and we're forecasting to break even. We are also forecasting to achieve our CIP for the year. But back to your original point, a lot of that is non-recurrent. So the process, I've already worked with the team to turn some of that recurrent last month, but we're going to focus this month because I think with an I&E break-even position and a non-recurrent achievement of CIP, we need to challenge ourselves to how we flip it all recurrent by the end of the year. So that's what I'm working through with the hospital leadership team over the next couple of weeks. Other than that, the IPR for Broad Green is very positive. So I don't think there was anything else really to escalate today.
Thank you. You mentioned before about the CQC visit a couple of weeks ago.
Yeah, so it was largely very positive at Broad Green. There were some issues around storage, which we picked up immediately with the teams. That was fed back on the day, and then each team picked that up. And there were some comments around hand washing. So again, we're picking that up throughout the sites with the IPC action plans we've got in place and the messaging that Jim referred to before. Other than that, David,
it was came across as very, very positive, particularly from the staff experience, and also importantly from the student perspective of their placements on that site.
Really good.
Yeah,
really good. Well done, Heather and David and everybody who was involved.
Yeah, the team's just on the point forward, the team's got immediate feedback at Broad Green, and we're all feeling really proud of themselves, and rightly so.
Tom.
Good question on the IPR. There's a slight spike in patients with no criteria to reside on the Broad Green site, yes. And it looks more dramatic than the way the graph is drawn, but is there a particular reason for it?
So there's two elements to that. One is part of our winter plan was to open an additional beds at Broad Green to support an entry site. So we moved more patients over to Broad Green, and they are patients who didn't meet criteria to reside. So that is one element of it. The other was around the same increase that we're seeing on the Royal and Aintree over the Christmas period. So I think it's spiked, is it at 70 something on there? That is back down in the mid 50s again today. So when you get the January IPR, you will see that they've seen that come back down.
Jim.
Chair, I thought either Nat or Pete might have mentioned that at Broad Green this month, the first robotic knee replacement surgery in the country using particular system has commenced. Mr. Phillipson and his team has started doing that. So that's a really great development in the site.
It is in the Broad Green report that was a business case approved through Aintree HMV, and the surgery takes place at Broad Green.
Thank you, Jim. It's good news. Okay, excellent. Excellent. Right, Liverpool Clinical Laboratories Management Board.
Thank you, Chair. So I'll take the report as read. Pleased to say there's no risk over 12, and we reviewed all the risks and above around 11. There is one matter that has escalated, and this is our continuing issue with industrial relations, in particular around the microbiology staffing. Now, we've set up 3 task and finish groups, one of them particularly around microbiology staffing, because of the perception around this that doesn't necessarily match with the data as we see it. So there's been really good engagement from all staff in this, and we're getting some feedback and sharing the data around our peer comparators to the other hubs across Cheshire and Mersey along and beyond where we looked good, but nevertheless the perception there. So in addition to that, we are implementing the allocate rostering system in that area, and that should be in by the end of the year, that we think will help. But there continues to be concerns from the union representatives. So we're looking to continue that partnership, working with them. The team are actually meeting the regional rep today to see if there's anything we are missing, but we can continue to try and get behind what the issues are there. There are two other task and finish groups where previously we've had feedback of issues. One is around the chemistry new IT system. Put everybody through a revised training session, dedicated session. Everyone will be retrained by March, and so that's been met really positively. And cellular pathology working environment is another area that we've had a further task and finish group. And again, we're putting additional monitoring equipment around health and safety. We're looking to invest in some new equipment to hopefully help the ventilation that is utilised in Europe, but not yet in the UK. So that it will be a first. That should again hopefully help show that we are reacting to the issues. In terms of the other issues, every issue identified has an action path. I'll just call out a couple that we talked about previously. The Clinicist WinPath system that supports our transfusion at Aintree. We're moving that over to the system used in the rest of the hospitals. That was, as you know, not supported from the start of January, and we're making sure that everybody has been trained properly. The IT, some issues with the printers. We've got a date now. They've all been tested. The 24th of Feb. Visited the team last week, and they're all confident of that switching date. So that's positive. The LIMS, there's two risks around LIMS, which is laboratory information management systems. That's a system-wide rollout. However, there's a business case going through because what our concern and the concern of the staff is the support from centrally and internally to generate that. So we put our request in and we await feedback on that. All of the risks have got mitigations. On other pieces of good news, thank you to Matt and the team, the phlebotomy booking system. It's been a long running open sore for us, and we've now got a system identified, and procurement is happening this month. That'll be in April working, which is positive. From our financial point of view, at month 9, we're 800,000 ahead of plan, 100,000 ahead of our CIP plan at 3.1 million. Challenge by the end of the year, we've got a forecast of 500,000 ahead of plan by the end of the year. And again, on the theme, we're projecting to hit our CIP with 60% of it recurrent at this point in time, but we're continuing to push. The final bit of transformational, which could be really exciting news, is that the board approved the outline business case for potential histology movement to a new environment 2 miles away from clinical labs at the Royal. This could be really transformational and take us out of 3 spaces at the Royal over to a dedicated unit, giving us extra space and unlocking some of the estates. So it's an outline business case. It will be going through the rigor over the next month, and obviously we'll bring that back to board. It will be valued by a board sign up if that meets our rigor. But that's an exciting one for the future. So happy to take any questions.
Thank you. So far, so good. Any questions? David?
Thanks, Chair. Great
Rob, thanks. Clear report, and it reminds us that we provide laboratory services to most of the surrounding hospitals. But you mentioned here that of the 17 SLAs, only 4 are assigned. Is there a business risk with that, or is that just a bit of administrative oversight?
Well, we also mentioned that £22 million worth of funds are flowing through the SLA. So there is a risk, although they are working and we're getting paid. We're part of an MIA audit. We're awaiting that response back from MIA. We think we are the exemplar actually in the organisation. It's often difficult, particularly in condensed periods where you're negotiating the SLA and the terms, and then actually getting somebody to sign it is but we're aiming to improve on that. But we'll report back on the NIA report.
Right, thank you.
Thanks, Ben. Yeah, just the risk around UNE and Trop T for the EDs, is that well understood between the 3 parties? Because it's in there as a 10. Both really obviously critical tests for ED departments to keep flow going. It says that there's some additional analyzer coming in February, but some phone call confirmations for Trop Ts and stuff started. So yeah, we don't need to get into it now, but it was just is everyone familiar with that? Is it a big problem? Is it not a big problem? Because it feels like it's a potential risk around ED flow.
So I think it is understood. It's actually been a useful exercise. Remember a couple of months ago we went into more granular detail on the IPR, and that's what threw out that this was one of the issues that was causing this problem in ED. So that's created this really short-term approach as to, as well as sending the results back, we'll phone up the ED and tell them the results are there, and this analyzer should hopefully improve, and if it doesn't solve it, we'll
okay, good, thanks, Rob.
Okay, thank you. Let's move on. Improvement plan. Tim.
Thank you, Chair. I'll assume the report's read and bring out 3 points from the report. First area I'll cover is sort of key risks and performance of note, and much of this has already been covered in the site reports, so I'll keep that quite light. I'll reference briefly the work we're doing with the System Oversight Group and in both trusts to progress forward stage we're at in the NHS oversight framework. And then I'll touch briefly on the group transformation plan, which is our improvement plan for next year and how that is shaping it. Colleagues will note it's a slightly lighter report than previous months. We've moved the performance dashboard and the highlight report into the information pack. It is still included in the board papers, but we're conscious of the 600 pages in the pack, so we wanted to slim that down. Briefly on the sort of key risks within the women's, Jen's already mentioned about the consultant anaesthetic risk, and there is really encouraging work going on between the anaesthetic teams at the women's and at the Royal. That's, as Jen mentioned, going to be a project in the improvement plan next year, and I think will be yet another example of the benefit of us working together under group structure and progressing a long-standing risk for Liverpool Women's. One of the other main risks on the women's improvement plan was around the blood transfusion robot on site, and there've been some delays with the procurement process. That has now restarted and is now planned to have the procurement concluded and the kit bought by July and installed on site by September, which meets the objective we were having when we first encountered the risk. They'll have it on site in H1 of next financial year. So that's encouraging. And as Jen said, the trajectories around the cancer recovery around faster diagnosis standard, where we're seeing 3 points above the mean, and also for the 6-2 standard, 2 points above the mean, suggests that work is heading in the right direction. Within the Loft improvement plan, we've already focused on this. Much of our main focus is on cost improvement and trying to deliver the 99.6 million target that we have this year. As at month 8, the full year effect of what we delivered at month 8 will be 63.6 million transacted, and 41 of that recurrent. It's a movement in the right direction from the previous period, and Rob has month 9 in his financial report, and you'll see the numbers are continuing to move in the right direction, albeit there's a gap, but we can see definite movement in the non-recurrent revenue in the right direction. I'd also draw out in the Luft improvement plan, encouraging continued improvement on uncapped theatre utilisation, where we can see 8 points below the mean. So suggesting the work being done in the site and by Beth's team is bearing fruit on those programmes. They're happy to take any questions about the improvement plans generally, but they're the things of note that I was going to draw out. Touching on the system oversight group, we are doing, the executive teams of both trusts are working hard with colleagues from the Integrated Care Board in the system oversight group, which is the group that brings additional oversight because we're in segment 3 of the NHS oversight. To say, we are trying to evidence that we are progressing against the exit criteria that we have. So we're in the 3rd tier of the oversight framework, and we're looking to get segment 2. We previously reported to board that we had a meeting in November where we ran through all of the exit criteria for both trusts. And we've since had a letter back from the Integrated Care Board recognising the progress that both trusts have made against their improvement plans and the exit criteria this year. So the domains assessed are operations, finance, workforce and quality. And it's been recognised that on our workforce for the work we've done on reducing agency spend and on our cultural improvement plans in both trusts, that the exit criteria has been met. So that's really encouraging. And we've also been able to get to the point where we think the only metrics at the end of the financial year that we will not be able to have evidence delivery on are the financial metrics and potentially elements of the cancer improvement plan of the women's, although that is now on trajectory. So the output from the meeting we've had in January is that in March we will be doing assurance reports for within Luft, the financial plan, our CQC must-dos, and our medicine safety programme to evidence we're on track with those programmes. And in the women's, it's the financial plan and also the cancer performance. So it was a really encouraging meeting. The ICB have positioned in the meeting that we've just had that we will use the May meeting to do a full run through of all the exit criteria, both those that we've delivered to evidence trajectory and those that they still have some concerns about. And then in May, they will be able to reflect back where that will leave us for progression out of whether we can progress out of segment 3 of the oversight framework. The slight unknown spanner in the works is that NHSE is currently redesigning the NHS oversight framework. So how that leaves us for next year, we're not quite sure. But I think it's encouraging that sort of partnership approach and saying these are our exit criteria and being very clear where we are against the delivery is continuing to work with our stakeholders. Lastly, as mentioned in the report, we are now shifting our attention to next year's improvement plan and what we're calling the group transformation plan, recognising that it's going to have a dual focus. The first is programmes that are very much with the group, both on group development and with our partners. So that's things like our last programme, which is the work of the Liverpool adult and acute specialist providers, and also moving to a focus of site improvement plans. So the improvement plan has been really successful over the last 2 years and in the women's. We now want to really embed that within the sites. So where Pete earlier talked about we need to have a focus on whether it's orthopaedics or head and neck, we'll be bringing the improvement plan methodology and some resource to really help the operational teams to take those programs forward. And linked to that, Rob in his paper will report on the CIP challenge for next year. We're very much going through, if we're having programs in the group transformation plan, they need to be making a significant contribution to CIP, and we're working through that as an executive team. So they were the 3 things I wanted to update on, but happy to take any questions.
Thank you, very clear. James?
Just a clarification point on the SOG process, the system on-site group process. Because Tim mentioned CQC must-dos, we haven't got any. So we need to be clear with the SOG process that if you have must-dos, which the women's did last time, and therefore that carried through the improvement plan, so looked, we haven't been notified of any. So hopefully we would be able to avoid the having to feed back on CQC to them.
Good point. The progress on the anaesthetists working together across two departments, and the progress on the blood robots very encouraging, because you know these were two of the big brought forward clinical issues from when the board met. So that's good. On the oversight framework, we came in the euphoria of coming out of 4 in that 10-minute window. We got excited about coming out of 3 quite quickly, and and here we are still doing it.
I think realistically, again, as Tim's just said, we don't know what the next framework's going to look like. But my guess would be, if you think about it simplistically, organisations in that overall previous level 4 was national intervention, wasn't it? 3 was local intervention. Now, if you move people to 2, it's almost you're on your own now, you're okay. And I'm not sure anybody's going to be going to 2 where the financial problem exists. And I think what we'll see is actually probably a revised version of this that starts to categorise 4s and 3s on money. Because I just can't see them moving away from any sort of regional or local intervention when the deficit positions exist as they do across virtually every organisation with an acute front door in each of the systems. So we'll wait to see. But my gut feel is that, and where we should be really, is we shouldn't have the oversight conditions against our name on performance or operations or people or those things that have been there for a while now. At either site is my view, although the women's cancer work is, you know, if it carries on its trajectory, you would like to think we should be off on that. But we would have to hold our hands up and say on the money, we would fully expect still to be in a SOC 3 type environment. So we'll wait and see what they come up with. But my guess would be you can't move a lot of people to 2 and then have a hands-off approach when the money's not where it needs to be.
Yeah, thanks, Chair. I mean, I think segment 3 of the NHS oversight framework is, I can use a football analogy briefly. It's a bit like the Championship, and for those that aren't football fans, that's the division below the Premier League. And you often see lots of very established names go down to the Championship, but very few come back up quickly. And actually, one of the things we used to talk about a lot when I worked in NHS is that hospitals go into segment 3 and they can spend years in it, and the oversight that's brought by the Integrated Care Board very much becomes sort of business as usual and doesn't do what it's intended to. I agree with James. I think what we're striving to get to is we've delivered all of the exit criteria that we feel in our gift to do so, and I think it will be the finance that we expect to have ongoing oversight in both trusts next year. But if we can evidence that we've done everything else, that's a good place for us to get to.
Great. Thank you. It's clear. Tracy.
Yeah, I would agree with that. You also don't want to go up and then bounce down.
Absolutely not.
Absolutely. I was just going back to that blood transfusion project and obviously the robot. Clearly there have been delays because of the procurement and all that, do the due diligence, etc. It mentions here about the repertoire of tests, and that might actually mean that it threatens the September go live date. I presume the tests full repertoire is available eventually. It's just a timing thing. Otherwise, it's would be concerning that it didn't actually deliver all that we wanted it to do.
Yeah, I'll pick that up. So we had our latest improvement portfolio board yesterday, Tracy, and had exactly that discussion around not waiting and getting that full repertoire right in from day one. So that should not be risk in terms of full repertoire being set up for the September go live.
Yes, we won't lose anything. In fact, benefits
all the benefits that we set out in the original procurement.
Financial report, please.
Great, thank you, Chair. So you've heard from the sites and the financial performance, and I'll take the overall paper as read, glance a few things, including the conflict was Cheshire and Merseyside remains a challenging environment. To state the obvious, the plan at the beginning of the year was 150 million deficit that was effectively funded cash back by NHS. As at month 9, the system's 56 million away from plan, with a risk-adjusted forecast of around 222 million. So quite a way off plan as we stand, and you'll see page the split of that, and it is split both across providers and in the ICB itself. Some of the challenge there. So that's the environment we're working in. Actually, at month 9, the organisations saw an improvement, as we've heard from Liverpool Women's head of plan, by £400,000 and forecasting to hit plan. Luft overall is away from plan at month 9 by £2.9 million. That was actually a halving of the variance from month 8. So that was really encouraging. A large part of that was to do with early transacting an achievement of the last savings. So we've got 15 million and we were able to transact 5 of that already at month 9, and all of the 15 was in quarter 4. So that's encouraging. It does actually still leave us ahead of our trajectory on our risk adjusted forecast that we did with Simon Worthington and the NHS ET earlier in the year. So we're about 2.9 million ahead of that. But the predominant reason is the last work. Then that brings us on to CIP. CIP, as we've already heard, the position at the women's going to hit the target for a shortfall on currency, and it looked as at month 9 with just under £61 million transacted. The encouraging thing with that is, whilst only 33.8 million of that is noted as recurring year to date, the full year effect is actually 68.6 million. And that was a real push by the team. So thank you to everyone, real collective effort of moving that dial from month 8 when. So that was a £23 million increase in month 9 on full year effect of recurrent impact. That again was influenced by our recognition that the 11.2 million system stretch, which is within the 15 from other organisations, would be recurrent. So we booked that in to that number and recorded it as such. Thinking about what can we do and how do we push this further forward? Firstly, I think both organisations, we're not going to give up the ghost. You've already heard colleagues as they're saying we recognise, and you'll see later on, there's a one-to-one relationship between the challenge next year and what we do this year. So stating the obvious, the more we do, it's perceived easier it is next year. Last night I had a meeting, part of the last work with CFOs and all CIP leads, and you're surprised it was a really positive and energetic meeting. And I think the first time people were really open, saying what can we do together. NHSE have produced a really good, really good productivity and efficiency plans based on data. And all organisations agreed that we would consolidate those, look at them across the patch within the next week, and then see what it is, where the opportunities lay, and how we get at that collectively. So So I think that's the answer, actually, part of the answer to this. In terms of the responses that have gone in this yesterday, ahead of the planning guidance, so this is just initial responses. The CIPs between the group range from around about 3% to 5.5% of operating expenditure. So there is still a range, but getting at that data is going to help us target it, I believe. Just concentrating on a couple of other issues. We continue to have conversation around our extraordinary items, and that includes a legal claim that remains in our books. There's an update later on the progress on that. We've got conversation with NHS tomorrow, actually, to update where we're up to. Similarly, the new hospital, where we continue to for the monies that were previously provided but non-recurrently, 42 million. And then the third extraordinary issue is no criteria to reside, that we've talked about a lot today, and loads of great work going on, loads of system work, but we continue to use effectively around 25% of our bed days on this cohort of patients who can be better served elsewhere. So that equates to around £50 million worth of resources. So tackling that issue will have a direct effect financially as well. Final issue just to mention is cash. Jenny's talked about Liverpool Women's. I don't think there'll be further cash requests from Liverpool Women's by the end of the year. There is a cash request from Love. We received already 25 million in September, as you know, national team. In January, we asked for 15 million and received 5. As at today, we've got 12 million pounds in bank, which is under 3 working days. So we have to go through this system now of monthly requests, and we usually don't get what we ask for. So it's a really detailed process, but we'll continue to do that on behalf of the board. Happy to take any questions. Yeah.
Well, I'll come to you, Matt. I will. So we're almost into month 11 of the business year now, and have a discussion later today about some of the issues in the plan next year. So unless there's points of clarification, questions on this, I propose that we have the board of finance discussion part of the later agenda item. But any points that any member of the board wishes to raise on that now, I'll take on the public record.
Thanks, Chair. Rob, you mentioned there was variation in CIP targets last year across last organisations. Do we see next year an appetite to be more equitable and harmonise that sort of thing together?
Yeah, well, I think so. And I suppose that's where I was talking about the energy and frankly a different approach from the 5 organisations last night. We're developing as part of the last work a financial framework, and that's leading a chapter on CIP and how we adopt that across the patch. The challenge we are going to be set is for hitting the target as Liverpool as a whole. There'll obviously be an organisational ask within that, but really the ask for us is the 5 of us. How can we improve from where we are now?
David, do you need to come in now?
Just a minor point for clarification, please, if I may, Chair. The Royal and I think the Aintree report mentions that the reports are prepared on the assumption that winter pressure costs will be funded. Is that a valid assumption?
The reference there, I think we talked about it. We have not been funded by the ICB. but we did set aside winter funding of £2 million that we allocated to.
That's funds we've created ourselves rather than national fund like we've had in previous years.
Yes, that's something that we received.
Thanks, Chair.
Could I ask Rob, please? Was there appetite for looking at workforce collectively, given the tight financial controls we have on us, and looking at that as a part 5? I'm really hoping there might be some glimmer of hope there.
Well, we're talking to finance professionals, so there was. I think we've got to translate that into those detailed plans and workforce plans across the organisations. And I think the truth of the matter is probably that what we know that the controls we've got in place are really restricted at the moment. That's limited to Luft.
I think it would be really useful for chief people officers and chief finance officers to get together quite quickly, I think, within last, not just us meeting separately. I will take that forward.
Great. Thank you. All good. Right, noted, and that's we'll pick up the conversation as the day progresses. Maternity incentive scheme. Year 6, January 24 update, David.
Thank you, Chair. Thank you. And colleagues, I'd like to formally thank my colleague Angela Winstanley, who's the quality and safety matron in maternity, for attending and being good. Thank you, Angela. So colleagues will recall that last month when we had, our last board meeting, when we had colleagues from the LMS here, we went through this paper around our compliance against and safety actions and standards of the maternity incentive scheme for this year. And we were able to make confidence that those standards had been achieved. I'm pleased to say this month those standards still remain achieved. And so we go with the guidance that we received at our last board, that the annual statement can be signed off and formulated through board so that we are able to apply to that incentive. I don't really have any other issues particularly pertinent to the CNST standards. Happy for us to take questions, but I think probably the greater discussions will be in the latter paper.
Okay, thank you. Welcome, Angela. Thank you very much for coming.
Thank you for having me.
Anything that you want to add?
No, you summed it up perfectly.
Okay.
All by myself.
First time that's ever been said in before.
Please, could
we Thank you.
Thank you. I'll take us up. Sorry, I'll take us on to the next paper, which is the perinatal quality surveillance and safety dashboard. And colleagues, just to give a précis, and I know that colleagues have seen this before, that this is a model that's intended to prospectively identify trusts and organisations that would require support before any serious issues occur. And this tool has been set up with a range of particular safety standards. And as part of that guidance, the development of locally agreed dashboards, it is required. The information is all within the paper, but what I'll do is if I just take you through the narrative, which starts at page 6. I won't go through every section, but there are some issues for us just to take note on. I think it was brought up, I think Jackie brought it up earlier on around the issue around induction of labour and some of the results from there. We've been able to see that there has been a return to a more accepted rate of induction of labours over the past few months. Obviously, what we need to make sure is that becomes a statistically significant reduction, and so that we can see that. There haven't been any cases for referral to the maternity and newborn safety investigation group. And equally, there will be no PS for the month of December. I appreciate that we've had some reports of further issues later on in January. I won't go through all the others, but I will just pick out two issues really for notes that there remains 47 open risks within the risk register in family health division, and you can see the breakdown of those within maternity and neonates, and all of those are in dates that have been reviewed and are discussed at the hospital leadership board. And has been mentioned previously by colleagues, there have been safety champion rounds. There were 24 of those that were carried out in December, and there were issues identified, particularly around the quality of signage and some of the digital records that required attention and improvements. However, there were some positive notes, particularly around the quality of the electronic system for the management of booking of scans. I don't have anything further to add. I don't know whether
Thank you.
or any questions from colleagues.
Question. Question. James. Jenny.
It's not a question. I think it's just one other thing to draw out, which is the lack, and James alluded to the lack of vacancies in midwifery and the work that's going on there. And there's some really proactive work around using fixed term midwives as well to make sure that we've shored that up and really have that consistent approach. So I just wanted to bring that out.
And again, I think that's part of the lesson that the rest of the organisation will learn about, particularly when there's peak activity in different times of the year for some of our specialities.
Yeah, it was really good to see the progress that's been made in both of these areas, and I know a lot of work has gone on from the team. So it's great to see that, especially as Jenny's just said, in terms of the vacancies, but also an improvement on the training rates as well. There's been a huge increase. One question that was really actually for David, really, as chief nurse, obviously in the group model, was how do you get specific oversight? Obviously, the meeting structures within families, and obviously it goes through the HLT and obviously the hospital management board. But as chief nurse, how do you get that assurance in terms of the quality of care and the compliance against these standards?
Obviously, I receive some of the data information, so I can look at that. But importantly, I have structured meetings. Diane Brown, who's the director of nursing of the site, where we will go through the information so that I can or be provided with greater depth of data and information. Also, doing walkabouts myself with Di and others around the site, and again, importantly, liaising with Becky Bird as our NED champion.
Yes, Sarah, sorry, sir.
First thing, to come back to a prior report as well, but I just wanted to note that it's good to see the compliance improvements in news, because that's something that we've had a lot of focus in quality. So I'm kind of scared to take that now as report. Also wanted to draw attention, it's raised in this report about the honeysuckle team. So we're very cited on it as NEDs having come through means, but I actually think it'd be worthwhile as perhaps bringing Mark from the LFC Foundation and Marie in for patient stories. I did a visit with the Honeysuckle football team in the LFC Foundation last week, and listened to a lot of the dads' stories. There was one father who had come for the first time, having lost a child, that will have appeared in this report. So you see immediately the difference that that's making. Marie and Mark were actually invited to Sri Lanka and presented at a conference just before Christmas, where what we're doing here is seen as a global standard for bereavement care, and particularly with a focus on fathers. So I think it'd be lovely for the board to be cited.
Yeah, that's really helpful. Thank you, Sarah. I actually been in a discussion with Daniel around that. What we need is we need to have a regular place on our patient stories from Women's Hospital on a periodic basis, so that we all get a lot of that sort of experience and understanding. But also it'd be an opportunity for some of that information to be explained. That's a great example.
And they are finalists at the Mariposa Awards in March for bereavement services as well. I know Marie Kelleher was a finalist last year. And Jen Deeney is up for Northern Power Women's on this.
Excellent. I'll jump out and playing for them next.
Thank you.
We through, Paul, David?
Thank you very much.
Thank you. Learning from death, Jim.
Thank you, Chair. Standard format, portal recognises Q1 learning from deaths for Luft. The first part of the report are the mortality indices. You'll see crude mortality, SHMI, shimmy, and HSMR as I report each quarter. And you'll see that we are on the right side of the statistics as far as those three parameters are concerned. I've shown you the funnel plot that identifies Aintree and the Royal separately and shows where we are. And a reminder that for Luft, we're talking about in the region of 3,500 deaths per year. So it's an illustration of the activity that's going through the organisation. So that's all very good, isn't it? So then the report goes on to say, but we're using these statistical markers to identify areas where we want to have a closer look. And in this case, the markers are saying we don't really understand why biliary tract disease, why appendicitis, and why hemorrhagic anemia are flagging. So we're going to have a good look at those. So we do those in different ways. So for the biliary tract disease, we're going to pull the notes and have a good look at them as individual cases. Then we'll do that through the mortality assurance group. For hemorrhagic anemia and appendicitis, we'll start with coding, have a good look at the coding for those, and if that then flags some other issues, that's when we would take order. And of course, if they identify anything, I'll bring those back too. We are consistently hitting the 60% primary screening level, which was our standard, so we seem to have got that reliably working. During the well-led inspection, CQC colleagues noted that there is sometimes a delay between the deaths and the reviews, and wonder whether that means the opportunity for learning is to some extent impaired. I think that's a fair challenge. So we have already gone back through the mortality action group, assurance group, forgive me, to look at how we can improve that piece. So we'll pay due attention to that in the next phase, and we've arranged to bring a paper to the Senior Management Board on the 11th of March to update on that, and then we'll take that forward. I think Neil Jones reported that colleagues were happy to adopt a QI approach, quality improvement approach, to seeing if we can move that, and also really try and identify those cases from which we have the potential to learn most and prioritise those in the piece of work that we'll do there. We've noted, I wanted you to note that it links to the PISA paper that's coming up. There was one case which we recognised was complicated. It resulted in a death. It was a patient with a complicated aortic aneurysm repair. And we concluded that a multidisciplinary team review would be the best way to get underneath the learning from this piece. So that is a particular aspect of PISA where we're going to drill in that way. I'll feed back in Q2. The themes emerging from Q1 included queries about the correct placement of patients coming through the emergency department. This is Q1, remember, so we're going back to the start of this financial year, but a recognition that teams really need to understand some of the quite complicated pathways that we've had to create in order to manage flow through the system. And I think, in fairness, a lot of that has worked through now, but that was being identified in those learning pieces. And also a reminder, really, some focus on documentation, particularly in relation to the Mental Capacity Act, which have been picked up. So the recommendation from this paper is for the board to note our processes, to recognise the statistical alerts that we have picked up and the work we're going to do in that regard.
Are you coming on to the Liverpool Women's Room?
I am.
Okay. Okay, so on the Luft report, any points, question? Thank you. Okay.
Thank you. I'm grateful to Chris Dewhurst, the medical director at Liverpool Women's, for giving me a good course in the data relating to Liverpool Women's. This report shows some numbers. It shows that in Q2 there were 2 adult deaths in the criteria. There were 5 stillbirths as categorised and 11 neonatal deaths. The 2 adult deaths, the learning or the views expressed relate to the difficulty accessing palliative care hospice beds, and that's actually an issue that we've noted before ourselves, isn't it? So that's interesting, and we will work together on that piece with Liverpool Women's. Then the paper talks about stillbirths and the data there. There's reference to the honeysuckle team. And in the paper, they identify the different categorizations of concern between A, B, C, and D. And the paper references some concerns, particularly to do with telephone triage, which are being addressed, and some communication issues which are being addressed. But the paper does not identify serious concerns in terms of clinical care. The paper then goes on to address neonatal mortality. There were 11 babies who died in that quarter. There's reference to the demographics of those babies, so that's considered. And there was one case where it was felt that in the antenatal period, there could have been better fecal monitoring, and that's being addressed through the system. The paper reminds the board that the medical examiner system for women's has come into place. I've reported that around Luft previously, that we've been running the system, but that's now brought all the hospitals into the same system. It's the medical examiners based in Luft who provide that independent oversight. So we've got a standard system. So that's the essence of the paper, Chair. There is then a lot of detail in data sets which are provided for national and regional audit, which I wouldn't propose to go through in detail. That's but it needs to be in the public domain.
Thank you. James.
Yeah, thanks, Jim. Well, firstly, great to see the ME medical examiner from September now at the Women's, because that independent view is really helpful. It was more a question just probably for you and Jenny, just about so learning from deaths work papers will feed through the quality group that feeds into your hospital issues. So do you feel you're getting the right visibility of this as it comes through to Jim here at board?
Yeah, no, absolutely. Through those routes, I think we have got to, because of the parent natal mortality tool and things, we have to report more at board, obviously. But the level I'm sure it's coming up is.
Thank you, Chair. Just in terms of the category C issue, reflecting back probably 2 years ago when some of the issues around MAU and triage initially emerged, these are exactly those themes. So although this is just one case, I'd want to ensure that we've got some more forensic oversight on that, because there was a big concern around human factors at that time. And this is about the decision making of those individuals in those moments. And when we're looking at category C or D, where that could have actually changed the outcome, we failed in monitoring, or we've not given the right advice to ensure people are triaged properly. Let's not wait till it's statistically different enough to make sure that we're really scrutinising that, because that's almost back, isn't it, 2 years ago, where we were on that real oversight of MAU.
Could I respond to that? So what I've got with my conversations with Chris Dewhurst, who's the medical director for Liverpool Women's side, is active, ongoing review of cases. So I'm reassured that I can see that happening. To link that to James's question, as we think about our governance going forward for a group, what we would do at the moment with the adult learning from deaths report is we'd look at that through quality standards group. If we create a group-wide quality standards group, we would give that same level of scrutiny and ask those questions in that space. So I think, but our plan, as you know, is probably to try and get that in place by April. So we're working on that.
Okay.
But it's work the whiteboards.
Yeah. Jackie, can you
Yeah, I think both papers are excellent and in the way that we're going forward. So the timeliness of those reviews is great to hear that you're going to be moving on that. And I think for Liverpool Women's, seeing that stillbirth rate come down, because as we know when we started, that's 3 years ago, it's really made a major change on those quality improvements that we've done. So I think it's good to see those changes.
Just wanted to say, I just want to check my understanding with Jim on that. So the timeliness of reviews for health, learning and deaths is what you're looking at, but I think my understanding of that is that the sort of triage process that goes on with anything significant will draw those out to be dealt with quickly, and the ones that wait longer would be the less high risk ones. So we might be missing an opportunity to learn from the less high risk. But I think I understand.
Well, yes, thanks for seeking that clarification. So just to reassure the board, of course, as you know, we have primary scrutiny with medical examiners. If there was what we would in old-fashioned language call an untoward incident, we would pick that up through our triage process in the PISA. So we would review those pretty much in real time. What we're really talking about then is this other group, if you like, of deaths who we're picking up and then taking through mortality assurance. So if there was something dramatic happening, I think that's picking that up quickly.
Yes, yeah, it's not that there could be something dramatic at the end of a long wait. Yeah, fine.
Okay. Thank you. We received those reports. Jim, you're still holding the mic on the draft patient safety.
Thank you very much, Chair. So this really needs to come to board in order to then go into the public domain. This is Neil and Claire's review of our PISA process through year one, and then the recommendations for taking this forward to now year two. What's nice is at the back of the papers, there's a letter from the ICB commending the process and recommending that this is fine to take forward. So very nice to get that commendation. I thought colleagues would find it valuable to see in Appendix A a list of us understanding where services are managed and where we go to if we need to pursue any cases in particular. And then there's clarity about the gradation of incidents and what we do under each heading. So we've got the national requirements, for example, a never event would require a patient safety investigation. And then we've got the local focus of identified it, so that we've got our triage process. We would look at cases against these categorizations and then take the cases forward accordingly. Do bear in mind that to do a full PSII will take at least 60 hours of a skilled investigator's time. So it is a significant commitment to the whole process, and certainly exec colleagues will know that we've discussed at length the resource allocated to it, and I think we've reached an accommodation in that space, but it's another challenge on our resource. And then actually to note in there the 416 learning responses that we've undertaken over time to give you some sense of the scale of the work. So Chair, this is for the board to note, please, such that we can put the detail in.
Okay, and which I think we're formally to approve this. Right, intend to do that, please. Well done, Jim. We're still with you on the Guardian of Safe Work.
Okay, thanks very much. 2 Guardian of Safe Working reports. Remind the board that these are contractual requirements, 2016 contract for what was then called junior doctors, now called resident doctors. And we have Guardians of Safe Working to protect the working lives of doctors. In Luft, we've got about 750 resident doctors. And of course, the arrangements of rotas across all of our sites and so on is quite a complicated business. So the Guardians, 3 consultants, link with resident doctors, are points of contact for them if they have any problems. And so 2 key things to note. Exception reports really occur when resident doctors have problems with their rotas. And as I reported before, when we get a new cycle of resident doctors, there are often some niggles about rotas and so on. So we'll often see the exception reporting go up and come down. And we've seen that this cycle. Immediate safety concerns are raised by resident doctors when they are worried about something going on in their day-to-day work. So they may be on a ward, for example, and worried about the workload that they're facing and the support that they have. So for Luft, in the quarter, we reported 23 immediate safety concerns, and they're broken down in the table. So I've met with the guardians of safe working. There's quite a lot of them that still reference the general surgery rota based at Aintree. There's some interesting nuances in there about not just about other doctors, but about the skill mix of the teams operating. And actually, phlebotomy is an issue that's raised sometimes. So you could have resident doctors working very, very hard and finding themselves doing a whole lot of tasks, which in other areas are undertaken by different skill mix. So it's interesting to pull out some of these things that we are continually finessing. But in fact, in relation to that general surgery rota, there is already movement on some of the other the hospital sites. So I made reference to the ENT rotas at Broadway moved. So I think that's been addressed. And my take with the three guardians for Luft was that they thought that by and large our resident doctors were comfortable with the responses to their concerns. And we've got a forthcoming resident doctors forum, which I'll be attending to meet with resident docs and get under the skin of that. So what I'm trying to do with this report is minimally edit it so that the essence of the concerns come through as realistically as I can bring them through. So I think that's an important piece, and I'm pleased by the response from the organisation to those concerns as they're raised.
Thank you, Jim.
That's the Luft one. And if I may, Chair, then grateful to Kat Pavlidis from Liverpool Women's, who's the guardian there. I think what's pleasing in this report really is Kat reporting that there were very few shifts uncovered at Liverpool Women's, and when they were, the arrangements to manage those safely are in place. Really minimal concerns coming back in terms of rota coverage, which, as I understand it, was not always the case. So that's very pleasing to see.
Thank you. Well, in this business year, in previous quarters, both the previous Luft board and the previous Liverpool Women's board, we've had presentations from the people involved, which was good and good discussion at that time. And I think that the reports, the quarter three reports, have reinforced the progress, good work that's going on. Any points, questions? Okay, thank you. What's received? What on Jim? We now the sustainability plan and welcoming colleagues for this.
Okay.
Hello. So it's a very comprehensive plan that we've received. Please take this in the spirit in which it's intended. We've allocated 10 minutes for this item, which would include discussion. So if we take it that everybody's read the full document and been impressed by it. If you just focus on the key issues for us as a whole of the day, please.
Yeah, certainly, Chair. Thanks. Yeah, as you say, the documentation there is quite extensive. Nicola Daly's with me, who's the sort of arbiter or the keeper of the tomb, so to speak. So a lot of the work is in Nicola and Nicola's domain and her team, as well as the wider engagement piece that we've been doing in this regard as well. So just to explain a little bit in terms of the previous, what we call sustainability strategy in the past, was due to expire in 2025. However, much of the guidance has changed, and the guidance that's in the new NHS net zero carbon plan, which is mandated for all trusts, they've moved the targets and changed various different elements. Also, the way that we record carbon as in accordance with the latest guidance is completely different to what was in the previous strategy. So this is an update of the previous strategy to bring it up to date in line with those elements. and we now call it a green plan rather than a strategy. Excuse me. It's also worth saying that Liverpool Women's Hospital have approved theirs in October, the equivalent documents. This is the Luft Green Plan, and we are working and in dialogue already with Tom Farrer around the last group. And this is one of the things that Tom and I agreed last Friday. It's relatively simple. He looks after two parts of that already anyway, to align. Nicola and the team already provide support or coverage for most of the last group anyway in respect of sustainability. And perhaps the most important part of that we've agreed that we need to do is to look at what we call the carbon decarbonisation plans, which effectively deliver this strategy. And there will be one of those plans, I imagine, for each of the 4 sites. And since Luft already manages energy on 3 of the 4 sites, with the exception of Liverpool Women's, which we also support separately, it's relatively easy to see how everything can be brought together under an umbrella document, albeit with each statutory organisation having its own green plan. So that's the sort of context, if you like. I'll very briefly touch on a couple of points in the covering paper, and then stop for some questions. Attached to the pack is also the travel plan and biodiversity plan. These were outputs of the previous strategy and they've been delivered and therefore are here as part of this refresh. Also, it's worth saying that for colleagues that may be particularly interested or not fully aware, that the targets around for the NHS around decarbonisation, they are now changed. It used to be target 50% by 2025. That's now been changed and recognised the difficulty in making progress in that regard. It's been moved to 80%, so more difficult target, but 2032, but remaining with net zero carbon by 2040. Interestingly, Liverpool's targets, Liverpool City Region 2035 and Liverpool City Council area 2030, even more stringent. I guess they will be revised anyway. And certainly if we can't deliver ours in that time, then it's difficult to imagine how those sort of system partners would be able to be successful. One slight error in the covering paper, it does mention that the target was 80% now not feasible by 2025, but it was actually 50%. So that's just a little correction. You spotted that one. It's probably worth saying that it isn't actually in the plan or in its covering paper, but myself and Nicola had a conversation about where we're up to against that. You might be wondering where we actually up to. And I think, Mike, it might have been you last time I came and talked about this. Said, well, what about the figures and the progress? We actually believe we're actually against the new way of measuring against all of the outputs rather than just the original outputs, which were the carbon targets. We're around about 10%. That's 10% by 2024, still a long way to go to get to where we need to be. Probably in old money, that was more like 20% against what we used to measure. So we're in this transition. Still lots to do. How are we going to do that? I had a conversation only last week, I think, with Rob about where's the money coming from. I'm not asking him for it because I know he doesn't know where it's coming from. I think it's fair to say that for us to get to net zero carbon by 2032, 80% by 2032, we'd be needing to invest, by all the reckoning we've done with our advisors, we think it's in the region of 200 million. So how we would find 200 million pounds, clearly most of that would have to be central funded. And also there'd be a complete reliance on new technologies, which are still emergent. In particular, we're investigating geothermal at the Royal site in particular. We believe we've got a good opportunity around geothermal. So we're going to do some trial boreholes as part of the redevelopment of the site before we do any more building on the site. But also hydrogen is something that's often spoken about, as you'll probably be aware. There's still a long way to go with that, but it is getting closer faster. Hydrogen, geothermal and tidal in Liverpool is another key. That certainly the Metro Mayor is really keen to progress tidal barrage. So with those technologies coming into the economy, if you like, into the source of the energy, that's what will help us get to where we need to get to. But inevitably, there'll still be a considerable amount of investment needed. In the pack, we've listed there that we've made quite a bit of investment and we've also secured quite a lot of outside funds. So we've secured £1.7 million of grants. And we've got about another £2 million we're expecting to hear about shortly. We were recently awarded £500,000 from another fund. So we're quite active in trying to secure money. Some of that money comes with the necessity of having match funding, which obviously then creates something that we have to work through around the capital programme, where we're currently allocating around about £1 million a year just in terms of this, but it does cross over into things like backlog maintenance and site development plans as well. So, Kerry, if it's okay, I'll stop there and then leave a bit of time.
Thanks, Paul. That's very helpful. Thank you. Nicola, do you want to come and join in the discussion?
Yeah, if there's any questions, I'm happy to.
Okay. All right, great. Thank you. Which question, Mike?
Yeah, well, it's great stuff. It's the kicker that's the problem, isn't it? That nothing not to like in this, and then there's 200 million. So I think it's I suppose it's what is the ask of us, because we can't sign up at this point, I don't think, to a 200 million funded plan, and yet this is the plan that we're being asked to sign up to, and it's how it sits within those two spaces.
Just I'll collect up points, Paul. Tracy.
Yes, I mean, obviously it's very difficult to do justice. It's a very big subject, isn't it? And with those legislation changes, particularly last year, I was just interested around the biodiversity and the units that they have, you know, in the construction industry have housing, they have to offset, don't they? And there are a load of banks being set up around these biodiversity units and things. What, with some of the things that you mentioned here about creating a pond, wildlife park, creating, you know, a hectare of wild flowers, etc. So with the biodiversity units, you have to keep it for 30 years, don't you? So we talk about setting these up, but presumably there's a cost.
That's the ongoing cost of maintenance stuff. So you're going to do something, you say you're going to do it, but you've got to keep it going. You can't let it.
But is there a restriction? When we say we do these things, it isn't a matter of doing it and then changing our mind 5 years later. There isn't something in the NHS that says that we have to keep this going for certain time.
There's probably a distinction between some of the biodiversity work that we do because we have it within our gift to be able to do it. And then there's the biodiversity net gain, which is something that we're mandated to do as part of planning. If we say we're going to do certain things as part of the planning, then we are required to keep that for a period and report on it on an ongoing basis. So there's a blend of actions in there.
And are we as an NHS going to, with some of our capital construction projects, be tied to that or having to do that? And does that need to look into this? Okay.
Yeah, so as all major planning applications, we have to include 10% biodiversity gain. So that's a given, otherwise we don't get planning permission. It's not massively different than it's been for some time, where we have to plant trees if we take trees out and the like. And usually they ask for more to go in than we took out. The pond, for instance, is here on this site where we built an additional car parking. So we created, you may have seen in quite a lot of road networks now where you get a new road, rather than it all going to drainage, it goes to an open pond, and then that creates a habitat. And we've mirrored that basically, and obviously maintaining that in terms of fences and the like. But largely speaking, it should be self-supporting bio network. And all the master planning work that we're doing at the Royal and all the master planning work we're doing here on the north side all includes all of this as part of that, and way beyond the 10% gain in terms of that.
But presumably we need to be careful when we're thinking about changing things around on the schemes, whatever, not tying ourselves down if there are areas that we've signalled are going to be that and have to be kept for a certain amount of time. So that's all part of our thinking, presumably.
Yeah, absolutely. And when we do projects, we can also invest in other parts. It doesn't have to be it doesn't have to be ourselves. So with our contractor partners, we can say, well, we'll do something in a community setting, for instance. There's a big emphasis on that. So it doesn't always have to be what we do on our side. It's about that offset in the broader sense.
Thank you, Paul.
Thanks for that. Brand is really exciting, and Paul's and Nicola's enthusiasm. I think it spreads with every team they meet to get more and more people involved in this.
It's twice you've been excited.
I know. Well, I was going to say it's the most exciting bit of my job, but then I remembered that painting yesterday. I think.
Get back to your point.
Sorry, just on the 200 million. I mean, I think that to take kind of common discussions in the media, this is an area of growth, isn't it, and an area of investment. So I think this is somewhere where we have to change our energy offer as well. And in the green space, it's a growth technology. We're doing we're the first, I think, in the NHS working with the university on the geothermal, the tidal stuff is really cutting edge. So So I've no doubt that the 200 million is validly constructed, but I think that technology is moving so quickly that could reduce significantly. And B, I think this is one area where there will be funds, whether it's NHS or other, coming out that enable us to into money. So I don't think you're right. We don't have 200 million we can commit at this point in time, but I think that will hopefully come down and we'll be able to access.
We could just add a little bit to that, Chair. Sorry, Mike's point and Rob's point is absolutely correct. But as a, for instance, the energy centre at the Royal, you'll be well familiar with, the contract ends in 2026. The life cycle of the energy centre equipment ends in 2026. We've got to replace the contract. We'll have to replace the equipment. We might be able to string that out and spread it. Might be a revenue scheme, might be some other scheme. That will massively contribute towards net zero carbon at the Royal. We're putting a Salix bid in to do that. Salix being a way of getting free money, basically. When match funding starts to become a problem, but some of it has to be matched. So that bid is probably going to be about £25 million to renew the equipment. We've got to renew anyway, but we'll renew it with new technologies and hopefully hydrogen, and that's how we'll get there. So it's an absolutely fair challenge. I'm not coming asking for £200 million. It's more an indication, because I thought you might ask, as to how much might it cost. And that is a realistic figure, as Rob suggests, and that's to get to 80%. Funnily enough, I don't think it's exponential. I think once we get to that, because the technology is getting over the line with the rest, it's probably not the most difficult part. Ironically, the other way around to normality.
And that sounds great. And I hadn't realised that the boiler house, familiar with the boiler house Royal, and it does look a bit long in the tooth, but I wasn't aware that it comes to an end. Its life comes to an end so quickly. Before you said that, I was thinking more of the quick wins rather than the tidal barrier and the geothermal heat source. We've got acres and acres of roof, and I haven't seen a solar panel on any of our sites.
I hesitate to say you haven't been looking hard enough, but if you go outside, you see lots. And one of the things this year is proliferating solar everywhere. Yeah. So it's absolutely valid.
It's too crazy now. We've never had in this before. Thank you, Matt.
Yeah, no, I think it's a really good document. Well, we've seen through the new hospital programme the importance of smart hospitals in the role for reduced carbon. And I think there's a real, as we move forward, a real sort of partnership develop in terms of digital leadership within the states to really drive some of the agenda forward, particularly across not just the Royal, where we've got a new hospital, but across the whole estate. So we could use these data to inform our decisions around how we put technologies in place. So I'm really excited. I think it's really important, and it should be at the forefront of what we do.
Yeah, digital is one of the new strands that's absolutely in the new guidance. You're absolutely right. Yeah.
That's a good bottom line note for us to finish this discussion on that. Everyone content that we can approve this?
Absolutely.
Yeah. Very much. Thank you, Paul.
Thank you.
Nicola.
Thank you.
Daniel, walk us through the governance items with your usual focus and pace, please.
Okay, corporate governance manual. The board approved the corporate governance manual at its November meeting. One of the parts of the manual is we've developed a list of statutory roles that need to be in place across both statutory organisations. Since that meeting, we've undertaken a further review, making sure that it's compliant with NHS statutory requirements, and we've added a small number of posts that were missing from when we came in November. So we've added that in, that are in your pack. The other thing that we've put in place in the cycles of business, we will review the details on a 6-monthly basis that will go through the senior management board, and that will also come through to the board for any amendment. It will come as at least annually to the board as an assurance process. So we are just asking the board to agree the changes to the statutory roles.
Thank you. Great. Thank you.
In relation to the assurance report that all board members were in attendance at the Strategy and Partnerships Committee, and the details were in this paper. Obviously, at that committee, we reviewed the terms of reference and strengthened the terms of reference to give it a clearer focus. And obviously, just the details are here just to remind, put in the public domain, the discussions that were taking place. Obviously, there were no decisions at that meeting. Obviously, it gives details of the meeting arrangements.
Thank you.
There are two sets of meetings. Obviously, Tim in his update talked about the work of the Liverpool Adult Acute Specialist Providers Joint Committee, the last committee. Copies of the assurance reports go to all member organisations and board meetings. These reports give details of the two meetings on the 18th of December and the meeting on the 16th of January. So the latest positions in terms of the work of that committee and the decisions made by that committee.
Thank you. Steve.
Okay. And then the final one was just details of the nominations committee that took place in December. The nominations committee, the remuneration and nominations committee looked at two specific issues. One was in terms of making sure the appointments process at Liverpool Women's for the HLT membership was undertaken in line with guidance and to approve those appointments. And the other one, we looked at the process that was going to be followed by the group model for the Chief Executive Officer designated appointment.
Okay, all true. Any questions on any of the above? More straightforward. Thank you.
In
Women's Unitary Government.
Yep. So I'll talk about, obviously there's a few arrangements that we do as part of the statutory requirements for both organisations. In terms of the board assurance framework, I'll give a general overview. This will cover both. Board assurance frameworks, we've agreed as a group that we will continue with the current strategic risks that have been in place for both organisations for about 2 years. Those arrangements will continue during Q3 and Q4. During Q4, we're going to be having a board development session, which will look at what are our strategic risks going forward. One of the issues about the timing of that is obviously, as board members will be aware, there is an NHS 10-year plan review, and it would have been an ideal opportunity to actually think about what are the 10-year plans for the NHS to say, how do we link those risks in? Problem is that process is slightly behind schedule. NHS England are saying the outcome of the review will be published in spring, but the NHS spring is probably not the spring that we know. So we are expecting it will probably be June or July, which I call summer. But, you know, so we are going to still do the work as a board development session to review what our strategic risks are. In relation to the Q3 update, that goes through the governance structures. Each of the risks in both organisations are allocated to an executive director. Reviews are undertaken with those directors through the governance arrangements. In Liverpool Women's, it comes through a slightly different route. It's reviewed as part of the Hospital Management Board. In the Loft, it comes through the Executive Directors Group. Liverpool Women's, in terms of the risks, there is still one risk that's rated as significant that relates to the isolated sites that we've talked about at all the meetings over the last for quite a long period. That risk level hasn't changed. It remains at exactly the same risk level. But obviously the report notes the further work that's been going on to try and mitigate some of the risks. And we heard about some of that earlier today. And obviously the work that's taken place within the ICB. The four other risks that are rated as serious in terms of workforce, digital sustainability, financial sustainability, and health inequalities. And we've heard some of that as part of Jenny's update, and that it ties in with a lot of the risks that have been long-standing. Some of the controls are improving, but not significant enough to change the risk score at the moment. Two risks, however, have been proposed to be reduced. One was around risk 8, organisational change. We're proposing to change the score from a 10 to an 8, which is moderate. We've changed the likelihood and the control scores following the work that's been done about the group model. We still think there's further work to be done to embed some of those practices, but we feel that the risk level has reduced further. And the other one was risk 9 in relation to well-led. It remains a moderate, but the risk score, we're proposing to change the risk score from a 9 to an 8 because of improvements to the control system around the well-led regime. And obviously that comes to the board. It's gone through that structure and it's come here for approval of those risk scores.
Intent for that, please. We've discussed the issue across all the meetings.
In relation to the loft position in Q3, again, as I said, the reviews have taken place. There are 3 risks rated that's significant, which is the same as Q2. However, one of those risks has increased from a 12 to a 13 in Q3. So the 3 risks that are rated as significant are elective activity, urgent and emergency care, and sustainability. We've heard many of the discussions today about the work that's been done and the controls. The urgent and emergency care one increased in Q3, basically because of the increased pressures and therefore the strength of our controls were having an effect. And we saw the pressures that resulted, as we said, in the incident that was declared in January. They are kept under review by Natalie and Pete, and we will continue to look at those controls in line with all of the other risks that come through. One risk has decreased, which was in relation to risk 10, which was about partnerships and collaboration. And that takes into effect the establishment of the group during Q3, but also the work of last committee, and also the emerging additional work that's been taking place with colleagues in Merseycare and Alder Hey as well, which I think we'll see more of in Q4 as those governance and partnership working increases. So again, in Q4, when we do the review of both of these, we're going to do a bit of a look back. And sometimes people say the scores don't change that much from quarter to quarter. In the last one, we've started to do that review, and actually there's some really impressive results which we can see as part of the improvement plan. So 5 of those strategic risks, they're not changing scores because we've achieved the target scores set 2 years ago. So we set a target score of here's where we start off as a risk, this is where we would like to get to. And on 5 of the 13 risks, we've actually achieved the target score that we set just 2 years ago. And some of that's linked to the work as part of transformation. But we'll be doing a thorough review of both Liverpool Women's and Loft at the end of Q4. And that helps us set the tone for where do we want to be focusing our attention on strategic risks going forward in 25, 26 and beyond. So again, here for approval today.
Thank you. And the adjustments that Daniel describes, I think, are consistent with the discussions that we've had through the period in high risk areas on elective care, emergency care.
Yeah. The other papers in those sections, I was just going to say, see, there's the charitable fund committee that Jackie chaired. Jackie, I don't know if you want to give any update, anything else that's not in the report.
Yeah, so it just really to look for ratification from the board as trustee of the Women's Hospital charity around the agreement that we would go towards sharing an independent care with Loft. So we did that, and also we agreed a £47,000 application for expenditure around the Strictly Come Dancing, recognising the money it generates and the demand out there. So those are the 2 things I just want to bring up, but the ratification of that independent chair is important.
Thank you. It's very helpful.
Okay, and then in relation to obviously there was also within the women's, there's the audit committee's report, and Tracy.
Okay, just one thing to say that we had the engagement partner has changed from external auditors. So we've got Liz Luddington actually joining us. The rest of the team stay the same for consistency, but that was her first meeting at the audit committee. Audit committee went well. We heard from internal audit. They are slightly behind on plan, but no more than they have been in previous years at this stage. So hopefully they will get back on course, and they say that they don't think that will cause any problems as far as the head of audit opinion at the end of the year. The one thing that we did have though, and it was a late report, it should have come to the previous audit committee, was a report that got limited assurance on duty of candour. So we were assured that actually those actions were being undertaken, but it was just to raise that as to board really as a issue of concern.
Thank you, Trace.
And then in relation to the last, David, from an audit committee, there's the audit committee report. I don't know if there's anything you want to add to that, and obviously charitable funds as well.
So on the audit committee report, just want to pull out that we got substantial assurance from our anti-fraud report, but we learned that because of our scale, we've been selected for a review by the National Counter-Fraud team. And I met with them and they were very positive.
That's good news.
We're doing with MIAA on counter-fraud, identifying fraud. Weren't selected because we're an outlier. They were just targeting very large trusts. And and like Tracy's commented, our internal audit plan is somewhat behind where we hoped it would be. And we put an extraordinary meeting in the diary in February, and we hope that will bring us back on target. On the charitable funds, just want to flag up from that report, we're hoping to follow the example of the women's in raising the profile of the charity somewhat, and I'm pleased to report that near the entrance here, we're having a charity office, so can't get through the door without being tackled by somebody with shaking the tin. And we're hoping that we can extend that to some of the other sites as well.
Very good. Thank you.
There's one thing that was on the consent agenda, but we just need to make sure.
The accounting policies.
Which was the accounting.
Yeah, and that went through audit committee, was recommended.
Both audit committees okay with it? Yeah, David, Tracy?
Yes.
Okay.
And the auditors were happy as well.
Okay.
Yeah, just a quick point from the two audit chairs. Earlier in the year, David and myself met with auditors just as part of a general, how's it going, how's it feeling from your perspective? If we've got new people coming in, it'd be helpful if you might advise us as to when the next appropriate point to do that might be.
Yes, well, we were talking, I've had a meeting with them before we have this audit committee, and then clearly we have the pre-meets before the audit committee, half an hour with the auditors. We've been through about actually possibly getting the auditors together, just have a conversation about how things would move forward. So I think that's planning, isn't it?
Yeah.
Thank you.
And the auditors, our Luft auditor, saying they're already starting some of the pre-audit testing now. So hopefully there won't be any delays. We have a date in the diary, the 23rd of June, to receive their report on the final accounts. So seems to be going well.
I think just obviously from the women's side, because we've got a new partner engagement lead, I think it might be worth perhaps just having a conversation with her for that joint relationship.
Thank you. Okay. Please on all that time. Thank you. I think that the risk issues are self-evident through the discussion today. I've nothing new to add for that. Brought forward the harmonisation of accounting policies, the other items on the consent agenda. Anything anyone was supposed to close the meeting? Thank you all very much for your contribution. Good discussion, good meeting, good agenda. Good presentations. Meeting closed.